Afternoon. I'm Susanna Massardis, CEO for the Community Liver Alliance. And I thank you all for joining us today for the Eliminating Viral Hepatitis C Among People Who Use Drugs in Appalachia Summit. The CLA is a national nonprofit organization which provides education, support, and advocacy for the liver community. And we're so delighted to bring this programming to you today. I want to thank our planning committee members who volunteered their time and expertise to help bring this summit to you today. Our members include Dr. Ron Baldessari. He's also our summit facilitator, and he's a professor in the Department of Epidemiology, the Rollins School of Public Health at Emory University. And Jay Mason, who's the Director of Community Programs for the West Virginia CTSI Project ECHO. Terry Kemp-Nick, she's a certified telehealth coordinator with Virginia Hepatitis C Education and Patient Connection, Hep C, at the UVA School of Medicine, the Division of Infectious Disease. Sonia Kanzader, and she is the Associate Director of Hepatitis Policy Project at the O'Neill Institute at Georgetown Law. Michelle Rose, Manager of Population Health at Norton Healthcare. Deb Nichols, she's the Viral Hepatitis and Harm Reduction Program Director, Division of HIV, STD, and Viral Hepatitis at the Indiana State Department of Health. Adrian Simmons, Dr. Simmons, is Director of Programs for the National Viral Hepatitis Roundtable. Dr. Arisha Bauer, who's the National Director for the conference, Hep Connect, at the National Harm Reduction Coalition. Nick Boyles, who's the Executive Director at the Indiana Survivors Union. Louise Vincent, Executive Director at the National Urban Survivors Union. Jeff Messerly, Business Development for the Community Liver Alliance, and Amy Logston, our National Director here at the Community Liver Alliance. So please join me in thanking all of those folks for being a part of this and bringing this excellent summit to you today. I also want to thank and recognize our co-sponsors, the National Viral Hepatitis Roundtable and the National Harm Reduction Coalition, and our additional sponsors, AbbVie, Gilead, and UPMC. And we appreciate your participation. This was a very well-received summit based on the registration numbers, and our hope is to make this the first of a series based on your feedback, which leads me to remind you to please complete the brief evaluation and share your thoughts about the summit and what you would like to see in the future, what we can do better, and what you enjoyed from today's summit. It is now my pleasure to introduce you to my co-chair, Daniel Raymond, Director of Policy for the National Viral Hepatitis Roundtable. I am so beyond delighted to have Daniel be my co-chair for this summit. He's taught me so much during this process, and I know that you're going to enjoy today's summit, and I feel fortunate to have been able to work with Daniel and our committee to bring you this first summit. So please join me in welcoming our co-chair, Daniel Raymond.
Thank you, Susanna. I'm really happy to be here and happy to see such a great turnout. As I think you heard from Susanna's introduction, it took a lot of people to make this happen, and we benefited from all of the thinking and the collaboration and the ideas that have been generated as part of this process. I was very grateful myself when Susanna reached out to me several months ago to invite me to work with her on this, because this general area has been a passion of mine for several years. And I think that it's very timely that we're convening people to discuss this today, in not today specifically, but this general moment where a lot of things are happening. I think it's been on everybody's mind that over the last almost 2 years, a lot of our attention in terms of protecting our communities and our families' health has been occupied by COVID, but that has led to the risk that the deeper issues that preceded COVID, revolving around the syndemics of hepatitis C and substance use, have only taken deeper root. And that often these two issues are talked about separately, that they're strategized about separately, that they're handled by different programs, different organizations, different parts of local and state and federal government. And our hope today is to bring these two issues, viral hepatitis and substance use, together in a meaningful way where we can identify opportunities to tackle them in tandem. And make the case that that is what will ultimately be necessary to move our communities into a healthier, more resilient space. And I say that the timing is striking for me. I don't think we anticipated all of this when we set the date for the summit, but at the federal level, just a few weeks ago, the Secretary of the Department of Health and Human Services released the administration's overdose prevention strategy. And I think there's a lot of things to take heart from in the strategy that they put forth. As with previous strategies under the last two administrations, there's a clear emphasis on prevention and as well on treatment, with a particular highlighting of medication-based treatment or medications for opioid use disorder. But they also really, for the first time, elevated two new things, which are harm reduction and recovery. And we're going to be talking and hearing a lot about harm reduction today, but I think the opportunities opened up by this alignment bode well for both our ability to tackle the broader substance use issues in the region, including overdose, but also hepatitis C itself amongst people who inject drugs, and are going to be a needed catalyst for advancing the kinds of harm reduction programs and strategies that have for too long been neglected, marginalized, or underfunded. This morning, I was actually on a call with CDC and their state policy partners, and we were talking about the landscape for harm reduction, specifically around certain services programs. And I see the Appalachian region as a bellwether for where we have been and where we are going as a country around certain services programs, that there's been a tremendous explosion of progress in implementing these programs, passing state legislation over the last several years, dating back to, I'd say, around 2015, when we saw Ohio, Kentucky, Indiana all come on board. And of course, a lot of this was in the wake of the Scott County HIV outbreak, which saw nearly 200 people who inject drugs acquire HIV from lack of access to sterile injection equipment. So we've seen enormous progress, but also a new precarity has seemed to take a hold. So Scott County, for example, their county commissioners recently voted to rescind approval for authorizing the county certain services program. Now, there's a ray of hope that the city of Austin within Scott County did say, if the county's not going to step up, we're going to. And I want to convey apologies on behalf of one of our planned plenary speakers, Kelly Hans, who was spearheading that effort in Indiana, who is unable to join us today, but we will discuss some of those issues in the next couple of hours. At the same time, we saw in West Virginia, a state that has clearly been on the front lines of these crises, a heated debate within the state legislature about the future of certain services programs, and legislation passed that would aim to severely curtail their operations. And while we're still seeing how that's going to play out on the ground, I think there's a feeling that we're in this moment where, despite the progress that we've seen since 2015 in terms of expanding harm reduction in certain services programs, we still have a long ways to go in really embedding them in the fabric of communities and ensuring that they are supported not just on the policy and legislative level, but amongst the various stakeholders whose buy-in is so essential in making them thrive as gateways to prevention, to healthcare, to everything from vaccination to linkage to substance use treatment to housing programs and other forms of social support. So that's a significant context for me of the conversation that we're having today, as we are expecting new federal funds to become available for these programs. How can we think strategically to make sure that they serve the goals of advancing viral hepatitis elimination for people who inject drugs? Simultaneously, this weekend, some of you may have attended the liver meeting hosted by American Association for the Study of Liver Diseases, where one of our plenary presenters from CDC highlighted new data that showed that the annual number of people initiating hepatitis C treatment has gone down considerably between 2014 and 2020. Now, of course, the 2020 data is always going to be under the shadow of the COVID pandemic. However, we saw declines for years before that. And to get to the goal of elimination that we want to see by the end of this decade, we're going to need to reverse those trends and accelerate treatment, particularly for people who've been left out through various kinds of health inequities. And that particularly involves needing to make treatment more accessible and effective and available for people with histories of injection drug use, including current injectors and people who have embarked on their recovery journeys. We are also seeing federal leadership on viral hepatitis in terms of the release this week of a draft implementation plan for the National Viral Hepatitis Strategic Plan that the Federal Department of Health and Human Services coordinates. But there's been a longstanding frustration from advocates, from health officials, and from patients that we have not seen the mobilization of resources at the federal level that we need to see to make the promise of viral hepatitis elimination a reality. So today we're trying to have those two conversations in one place at the same time. How can we work on the broader substance use issues and viral hepatitis, in this case, hepatitis C, and people who inject drugs in tandem? What new strategies are surfacing and emerging from the field where we see the Appalachian region as not just a place that has had an intense burden, but also a proving ground where we've seen various innovations, various mobilization, and various new ideas come forth about what it will take to end these epidemics in tandem. So those are some of the conversations that we're going to be having today. And I'm inviting everybody to think as we're hearing from our speakers, as we're hearing from our panel, and as you move into our breakout groups, about what solutions and strategies you would like to contribute to this discussion that we could all share and collectively elevate and disseminate and amplify. And I mentioned new federal funding opportunities for harm reduction in certain services programs, but most of our states and jurisdictions are also looking towards both new federal resources coming down for substance use and behavioral health more broadly, but also potential opportunities as states and localities pursue settlement talks with opioid manufacturers and distributors, where discussions are happening in state legislatures and many other places about the best use of those funds to remedy and rectify the issues that our communities have been struggling with over the past 20 years. So that's the context that I'd like to set for this discussion. And I'm so grateful to all of you for joining us. We are about to move into a series of plenary talks, and we have some great speakers. My colleague, Dr. Ron Baldessari, will be introducing them. As Susanna mentioned, he's been both capable and able assistant for our planning of this process, a professor in the Department of Epidemiology at the Rollins School of Public Health at Emory University. But he also had longstanding roles in service in senior leadership in the federal government, including positions at the Centers for Disease Control and Prevention, the Department of Veterans Affairs, and the Office of the Assistant Secretary for Health at the Department of Health and Human Services. So I'm going to turn it over to Ron to moderate our next session. And again, thanks for your support and welcome to all of you, and let's have a great summit.
Thank you so much, Daniel. Let me add my welcome to the two meeting co-chairs. And I think Daniel laid out very nicely what we're all looking for as a result of this summit is what are some of the solutions that we can share to implement to improve the health of people who use drugs and are also impacted by viral hepatitis. We've set up the meeting to first begin with a series of 3 plenary presentations, just to make sure that everyone is kind of on the same page with information. After that, we will take a 10-minute brief break, and then we'll reconvene to hear from a panel of experts talking about various systems of care for people who use drugs. Then, as Daniel mentioned, we will go into a breakout session. There'll be 4 breakouts. You'll be notified which breakout session you've been assigned to. There is a moderator for each session, and that person is going to work very diligently to try to come up with 2 or 3 key recommendations that we can share back with the group when we reconvene. So that's a brief overview of what the day will look like. Let me tell you, you will get reminders throughout of how you can communicate with the various speakers. But now it is my pleasure to begin the plenary session with our first speaker, Dr. Iyasu Tishale, who is an epidemiologist in the Division of Viral Hepatitis Prevention at the U.S. Centers for Disease Control and Prevention. And Iyasu is going to give us an overview of the overlapping epidemics of hepatitis C and substance use in Appalachia. So let me turn it over without further ado to Iyasu.
Thank you, Ron. Hello, everyone. I'd like to thank the organizers for the opportunity to participate in today's virtual panel on hepatitis C and substance use in Appalachia. As you all are aware, hepatitis C is the most common bloodborne infection in the US, with an estimated 2.4 million people living with active hepatitis C, and 40% of those living with hepatitis C unaware of their infection. Injection drug use is by far the most common risk factor for hepatitis C. Hepatitis C is associated with considerable morbidity and mortality. As you will see from the following slides, the number of hepatitis C cases continues to increase every year, despite our ability to prevent and treat hepatitis C. Next slide, please. In the following 20 minutes, I will walk you through the epidemiology of hepatitis C in the United States and the Appalachia region, hepatitis C virus infection, and substance use during pregnancy, the syndemics of hepatitis C and substance use, impact of COVID-19 on HCV services, and federal and jurisdictional response to the syndemic. Next slide. Next, please. The number of acute hepatitis C cases reported in the United States increased every year during 2012 to 2019. During 2019, a total of 4,136 acute cases were reported, corresponding to 57,500 estimated infections after adjusting for case under ascertainment and under reporting. The number of cases reported during 2019 corresponded to a 14% increase from the 3,621 cases reported during 2018. Also shown in this slide is that the increase in rate and number of reported and estimated infection occurred both in the Appalachia and in the United States. Next slide, please. During 2019, the rates of reported acute hepatitis C ranged from a high of 4.8 cases per 100,000 population to a low of 0.2 cases per 100,000 population. The horizontal line separates the Appalachia states from the rest of the United States. The vertical line indicates the national average rates of hepatitis C. In 2019, the rate of reported acute hepatitis C in the Appalachia was higher by 20% than the national rate and 33% higher than the non-Appalachia states. While the rate of hepatitis C in the US was 1.3 per 100,000 population, it was 1.6 per 100,000 population in the Appalachian states and 1.2 per 100,000 populations in the non-Appalachian states. Next slide, please. In the following couple of slides, I will show rates in the United States on the right, and rates in the Appalachia on the left. During 2019, rates of acute hepatitis C was lowest among Asian Pacific Islander persons and highest among American Indian Alaska Native persons. However, the relatively small number of cases reported among these race ethnicity categories can result in wider fluctuations in annual rates. In 2019, rates were substantially higher among all race ethnicity categories. The most notable relative increase occurred among non-Hispanic Black persons and Hispanic persons. Next slide, please. The increase in rates of acute hepatitis C has been observed among both male and females. Compared to the rates in 2010, in 2019, acute hepatitis C rate was greater than 5 times higher for males and greater than 3 times higher for females. Next slide, please. This figure shows the incidence of acute hepatitis C among women of reproductive age. Along with the opioid epidemic, the number of reproductive age women who are infected with HCV is increasing steadily, posing the risk of mother-to-child transmission of HCV infection to their infants. Next slide, please. Rates of acute hepatitis C increased among almost all age groups above 20 years. The rate of acute hepatitis C has remained the highest among persons aged 20 to 39 years, similar to the age group at highest risk for fatal overdose. Compared with 2018, the greatest increase was observed among those aged 40 to 49, followed by those aged 30 to 39. Next slide, please. However, looking the age data by stratifying to persons below and above 40 years of age, we notice that the incidence was much higher in those younger than 40 in the Appalachian region than that's in the United States, indicating that this is the group where higher HCV transmission is occurring and contributing to the higher incidence in the Appalachia. We didn't see such a substantial difference by race and sex. Next slide, please. Among the case reports of acute hepatitis C received by CDC, data regarding risk behavior and exposure were missing for 45% of cases. Among risk behaviors and exposure identified, injection drug use was the most commonly reported. Next, please. And next. This graph shows maternal HCV status for women giving birth in US hospitals between 2000 and 2015, stratified by opioid use history. During that time frame, the rate of maternal HCV infection increased from 87 to 217 per 1,000 deliveries with a diagnosis of opioid use disorder. Among women without opioid use disorder, rates of HCV infection increased from 0.7 to 2.6 per 1,000 deliveries. Next slide, please. Along with the increase in the incidence of HCV among women of reproductive age, data from Kentucky shows that the proportion of infants born to HCV-infected women increased 124%, while that proportion increased nationally only by 68% during the time 2011 and 2014. Next, please. And next. So of the 3 primary blood-borne pathogens transmitted by injection drug use, hepatitis C is the most sensitive indicator of injection drug use. Across all these studies published between 2002 and 2014, from Seattle, Washington to suburban Connecticut, prevalence of hepatitis C is always higher than prevalence of hepatitis B, which is always higher than prevalence of HIV. Next slide, please. So what's driving these increases in overdose, death, and hepatitis C infection, and what parts of the country are at highest risk? This slide illustrates an association between several indicators and county-specific rates of amount of opioids prescribed on the top right, overdose death bottom right, and reported cases of acute hepatitis C bottom right. While particularly high rates indicated in dark red in the maps occur in the Appalachia, the West, and to some extent the Northeast, every single state has seen an increase in overdose deaths rates since 2010, and the same is true for hepatitis C incidence. Next slide, please. A number of HIV outbreaks occurred after the 2015 Scott County outbreak and showed that co-infection with HCV occurred from 88 to 94% of HIV cases that were detected as part of those outbreaks. In these HIV outbreaks, HCV was detected on an average 4 to 5 years prior to the HIV diagnosis. Next slide, please. In this 2017 study, geolocation of syringe service programs, shown as black triangles, was compared with zip code of residence of young persons testing positive for hepatitis C, shown as red dots, to determine the proportion of hepatitis C infected persons who lived within 10 miles of a syringe service program. 35% of persons in the West lived within 10 miles of an SSP, but only 10% of persons in the South lived within 10 miles of an SSP. The overall range was from 0% in some Western Plains states to 77% in New Mexico, and of course 100% in Washington, DC. Next slide, please. The correlation between substance use disorder and viral hepatitis does not stop there. Since mid-2016, we're dealing with outbreaks of hepatitis A primarily among people who use drugs and people experiencing homelessness. In this unprecedented hepatitis A outbreaks, so far there have been more than 42,000 cases, greater than 26,000 hospitalizations, and over 402 deaths. These outbreaks are causing more hospitalizations and deaths than usual, primarily because some have already damaged livers from co-infections with hepatitis B and or C. Next slide, please. And next. And this slide summarizes the impact of COVID-19 on syringe service programs in the United States. The data collected by the North American Syringe Exchange Network from 174 syringe service programs from March to April 2020 indicates that SSPs were significantly impacted by COVID-19, with 43% reporting decreased services and 25% reporting that they have had one or more sites closed. Next slide, please. To assess the impact of COVID-19 on hepatitis C testing and treatment in the community, our division worked with partners to evaluate data from large testing and treatment databases. This slide illustrates the estimated average number of HCV antibody tests conducted by WIC from January 2018 through most of 2020, and found that HCV antibody testing volume decreased 59% by April of 2020. Next slide, please. And this data from a national prescription claims database also corroborates the same impact of COVID, where treatment numbers decreased dramatically over prior year without other clear indications, clear reasons. Next slide, please. However, most important in treatment is actually the access to treatment. In this study of 60 young adults with new hepatitis C infection, 49 were confirmed as RNA positive, 30 accepted referral to HCV treatment, and 5 initiated treatment. All 5 achieved cure. There remain many barriers for PWID as exemplified by this cascade of care to access treatment, which would have cured infection, reduced morbidity and mortality, and interrupted HCV transmission forward. Next slide, please. And next slide. The United States National Viral Hepatitis Strategic Plan provides the strategic direction necessary to set the nation and a meaningful course towards achieving viral hepatitis elimination. One of CDC's priorities is to support health departments to conduct core viral hepatitis surveillance and prevention activities. In May 2021, CDC launched our new integrated viral hepatitis cooperative agreement. The funding opportunity will support 59 states and local health departments to conduct enhanced viral hepatitis surveillance and develop partnership for elimination, planning, and implementation, including partners who have specialized experience and capacity to reach people who inject drugs. Additionally, 17 health departments are receiving funding to improve access to comprehensive prevention, diagnostics, and treatment services in settings serving people who inject drugs. And these jurisdictions include Kentucky and West Virginia. The next slide, please. Furthermore, driven by a common goal to help support rural people who use drugs and their communities, the Rural Opioid Initiative, which is a collaboration funded by NIDA, CDC, SAMHSA, and the Appalachian Region Commission, brings together experts, physicians, epidemiologists, and behavioral health professionals from the substance use and infectious diseases fields to build collaborations between state and local communities and conduct research to assemble locally available data and conduct research to fill local data gaps and use findings from the rapid assessment phase to propose locally relevant intervention projects and implement interventions in locations that are actually shown on this map and beyond. Next slide, please. In conclusion, HCV infection is increasing in the Appalachia as well as the rest of the United States. Injection drug use remains to be the most common risk factor. HCV infection of pregnant persons and infants born to infected mothers is steadily increasing. HCV is both preventable and curable, and there are public health measures that can be widely implemented to eliminate HCV from persons who inject drugs. Next slide, please. I want to thank the organizers for the opportunity to talk on this topic today. Ron, back to you.
Thank you, Iyasu, for that very comprehensive presentation. We did have a comment about the availability of the slides. Let me just say briefly that the organizers of the conference intend to provide a high-level summary and copies of any slides at some point in the near future. We can't promise them by close of business today, but they will be available to participants at some point. And this entire summit is being recorded for individuals who aren't able to join, who can watch later. Now it's my pleasure to introduce Dr. Leslie Marie Buer, who is the Director of Research at the Choice Health Network Harm Reduction in Knoxville, Tennessee. And Leslie Marie is going to provide an overview of the interrelated policy environment that impacts both hepatitis C elimination as well as drug use among people who live in the Appalachian region. So let me turn it over to Leslie Marie.
Hi, I'm Leslie Marie Buer. I am the research director at Positively Living Choice Health Network. And we have offices in a few places in East Tennessee and outreach locations as well. And so I want to share the lens I am coming from, because I think that affects how we all, talk about our topics of interest. So I'm a medical anthropologist, and I think what that brings to me is, I'm really interested in structural issues, definitely not in blaming the individual or looking at individual interventions necessarily. And I'm also really interested in including the cultural beliefs and social movements behind many of the policies and politics we see, especially in Appalachia in the South. I'm also a harm reductionist. When I say that, I mean a harm reductionist with a capital H and capital R. And that's actually from a nice article in Filter that you see the title of here. And I encourage you to check out this article if you're interested in sort of what I mean when I say that. But I mean, for me, I think harm reduction is not just about reducing health risk. It's about supporting a social justice movement led by people who use drugs. That it definitely includes slinging needles and naloxone, but it also includes advocating for decriminalization, abolition, affordable and available housing, reproductive justice. You know, it's acknowledging all of the aspects of our society and environment that negatively affect people who use drugs. And also, when I say capitalized harm reduction, I'm pushing against a type of sort of bait and switch harm reduction that we are increasingly seeing in the South and in Appalachia, where people are sort of lured into a program because they're offered maybe a few bags of syringes, and then they're coercively guided to an abstinence-only treatment program, right after they're given some harm reduction supplies. Or what we also see a lot is people being sort of sold what they think is a buprenorphine program, but once they're sort of in, they realize that they will be tapered in very, very quickly, sometimes in 4 to 6 months. And then they're guided to use Vivitrol, which most folks we talk to, it doesn't work too well for them. And then there's also some peer-reviewed evidence that shows some overdose risk concerns with Vivitrol. And so when we talk about harm reduction, it's really about autonomy, not coercion, and about providing clear services that people say they want where they're at. So that's just sort of the lens I'm approaching this with. And so a lot of also what I want to talk about, and as a cultural anthropologist, is some of the cultural beliefs behind bad policies. And oftentimes when we think about bad policies, we want to sort of blame this omnipotent power at the top, or certain legislators or so forth. But these ideas are not born in capitals. They're born in our everyday culture. They're born in the places where people grow up and from the voters who vote people in. So when we talk about sort of bad policies, I think we all have to look at ourselves too, and what are we doing to support these bad policies? And so I just wanted to show some examples of discrimination in the place where I'm mostly at is in Knoxville, Tennessee. The one on the left, unfortunately, we see a lot on cars around town. And advocating this type of violence against anyone is pretty repulsive in my opinion. But just imagine if you're someone who connects people with drugs or cells, seeing this, it's telling you that your community wants you dead, it's really powerful. And the one on the right, I think, really shows, especially in East Tennessee, I've noticed there's a special hatred of pregnant people who use drugs. Honestly, there's a long history of hating a lot of pregnant people in Appalachia, whether they use drugs or are poor or are just in Appalachia. And so, but this is shown here. And what's so sort of heartbreaking about this is if you look at the statistics of babies in Knoxville born with NOWS, neonatal opioid withdrawal symptoms, most of those symptoms can be actually attributed to doctor prescribed buprenorphine. So this sign is basically telling people that they shouldn't trust their doctors and that they shouldn't be relying on evidence-based medicine. And so, all of these types of discrimination are influencing the policies we see. And there's this idea that drug use is a moral failing, and that idea is not going away. And thus people who use drugs deserve to be punished. But this discrimination against people who use drugs is also intersecting with other types of discrimination. And the sentence I just said, drug use is a moral failing, you can insert all sorts of things there. So people are also saying poverty is a moral failing, and thus people who are poor deserve to be punished. Or sexuality outside of heteronormative marriage is very heavily stigmatized here. Blackness is heavily punished across the US. So there's all these ways in which discrimination against folks based on maybe one action or their social status is turning into these policies. And of course, these aren't things, as much as I can talk about the failings of Nixon's drug policy and the failings of the war on drugs. We can't just trace these things back to the mid 20th century. They have deeper historical roots than that. Sort of a lot of this hatred against drug use is going back at least 100 years, and then hatred against people who are poor and all these other social places that people are holding. Long roots of discrimination, both within the community and within social systems. So example of social workers, of medical workers going into Appalachian communities from the early 1800s and policing people's autonomy and policing people's families, and sort of doling out a lot of discrimination and a lot of punitive approaches. So all that is to say, in order to work on these cultural beliefs, it's going to take a lot of community education and organizing to change these things. And sometimes harm reductionists are expected to do that, but it's hard to do that when you're also trying to deal with delivering a lot of services. And so any support I think we can have in doing some of that community education would be much wanted. But of course, these cultural beliefs do affect politics. And I know a lot of folks are very familiar with the policies that across the US that are threatening, ending hepatitis C and even preventing transmission of Hep C, even just to keep us at a stasis. With where that's at. And so I'm not going to go into things that I see as affecting sort of people across the board in the US, but I do want to point out a few things that may not be unique to Southern and Appalachian politics, but I think are particularly pernicious here. And so one is certainly the efforts to prevent harm reduction from even happening. So several states, it's still illegal to provide syringes. And even in states where it is legal, such as Tennessee, there are so many hoops to jump through to open a harm reduction program. It becomes nearly impossible to open up new ones because of sort of new policies that have been put into place. So if you have a program that has been maybe grandfathered into those policies, it's kind of okay. But if you're trying to open up a new place, it's nearly impossible. And a lot of that pushback, unsurprisingly, is coming from law enforcement in Tennessee at this time. In order to open up a new syringe service program, you have to have a letter of support from law enforcement. And politically in this state, a lot of agencies, law enforcement agencies, see that as political suicide. And so getting that letter of support is going to be nearly impossible. And they might tell you behind closed doors that they're okay with it, but actually giving a public letter to support a harm reduction organization, that's going to be a rare thing to happen. The other, I would say, biggest opponent to harm reduction are often realtors and planning commissions. And so a lot of that has to do with efforts to gentrify places, but also just efforts to prevent harm reduction from coming into a city. And so we've seen planning commissions oppose syringe service programs, as well as buprenorphine programs. across different cities in East Tennessee, as well as Western North Carolina, and maybe beyond that, but those are the examples I'm familiar with. And then you have efforts to fully dismantle harm reduction, which was unfortunately successful in West Virginia the previous year. And there's some data coming out of West Virginia. Of course, this harm reduction dismantling happened in the middle of an HIV outbreak, and that, of course, with no new syringes and no harm reduction program, that has continued to worsen, to my understanding of knowing some folks on the ground there. And so, and similar efforts were brought about in North Carolina to dismantle harm reduction in that state, but luckily those were thwarted by a very organized group of pretty amazing activists. So, some other things that are sort of affecting folks who use drugs here and preventing them from accessing services might be some evidence-based treatment programs, especially for substance use disorder, are often overregulated, and that is particularly true for buprenorphine and methadone. And you have law enforcement, staking out buprenorphine clinics, which scares people off. And then we also have a hard time for people once they do get a buprenorphine prescription from actually filling that prescription at a pharmacy. And there's a great recent article, it just came out a few days ago in NPR, that focuses on a few providers in Western North Carolina, so still in Southern Appalachia. And they really talk about how the DEA targeting of pharmacies who are providing buprenorphine services is really harming folks. And we know that if people can get into a buprenorphine or methadone services, oftentimes it provides a level of stability in their lives, which we know if people, that provides opportunities for testing for things like HIV and hepatitis C, as well as provides sort of an environment that makes it less obstacles, let's say, to getting HIV and hepatitis C treatment. On the other end of the spectrum, while all these evidence-based programs are being overregulated, we have an underregulation of abstinence-only treatment programs. Another good sort of a pop culture reference for this is there is a Reveal podcast about American Rehab, but they also offer some really good peer-reviewed resources if you go to their website and so forth. And it talks about how different abstinence-only treatment programs across the South, and we have experiences locally as well, turn into nothing more than work camps. And there's really not much treatment going on there. And these can be somewhat dangerous places. And some of the issues that come out of this are not only are you not getting good treatment, but we know when you go to this type of treatment, overdose risk increases dramatically when leaving. And it also builds distrust with the entire medical system. So if you go into something that you associate with the health system and it treats you poorly and doesn't really do anything positively for your life, you're less likely to trust the medical system and go in to get things like Hep C testing and treatment. And a similar process is happening with hospital IV drug use protocols, which have spread pretty rapidly in East Tennessee. But some of the first ones I was aware of were actually in Western North Carolina. And of course, these vary from hospital to hospital, but what it primarily entails is a lot of searching, surveillance, and criminalization of people who inject drugs once they are admitted to a hospital. To the point that it greatly, it completely isolates people, which with COVID-19 in hospitals right now, I understand that there's a lot of isolation happening regardless of drug use status, but this was implemented before COVID. And it has led so many folks to refuse to go to the hospital. One key thing is also they take away your phone completely. And if people know that they're going in for a long time, so not only can they not have visitors, but they also can't have a phone to communicate with anyone. So we have people who have said that they are refusing to go to the hospital because of the discrimination they face there. And they said that they would rather die, and then they have died. And then we have other folks who are, have said that I'm not going to the hospital until I go unconscious. And then they have a family member take them to the hospital. And at that time, it might be too late for anything, or it might be an infection has spread to the point where they have to lose a limb or lose certain abilities. And so, once again, this is just creating a complete distrust of the medical system. And it's really hard for people to want to go get treatment when this is what they think they're going to face or what they have faced in the past. And of course, availability of care is an issue as well. And so there's, of course, an urban-rural divide in availability of care. And if you see on the left-hand screen with pictures, shades of blue and green, the dark blue represents the urban areas, and the sort of white represents very unpopulated rural areas. And I've worked and lived in both of those shades. I'm currently in the dark blue, but previously I've lived and worked in the white. And I can tell you, I think there's a stereotype that all rural areas don't have health services, but I think that really varies by county to county and regionally and from state to state, depending on what type of health system you have happening in that area or state. But I would say overall that rural areas, there may not be an option for treatment available, for Hep C treatment available at all in the county. And especially it might not be available locally for uninsured folks or for people who use drugs. There might be simply a refusal to treat people who use drugs for hepatitis C if they are currently using. And of course, that can become the case in urban areas as well. And our experience working in both urban and rural East Tennessee right now is that there is an incredibly low availability for people who are uninsured for Hep C treatment. And it's an even lower availability for people who use drugs who are currently using. And of course, that results in really long wait lists. And oftentimes, having to go wait for hours on these wait lists and so forth. So it's just not easy to get. It is a triumph for us to get someone connected to care. And, we've RNA tested hundreds of people, and I think we've gotten a few in to actually get care. And that's shows a lot for what they did to do that. Just so many phone calls and so much waiting. So it's just not readily available for most of the people who we're serving through a harm reduction program. But so I feel like I've talked a lot about the bad stuff. And sometimes we get bogged down in that in harm reduction because it's just hard sometimes, but there are so many successes, and definitely from related fields sort of adjacent to Hep C prevention and treatment. And so I've lived and worked in both a Medicaid expansion state, or at least it was while I was living there, Kentucky, and now I live in a state without Medicaid expansion. And I think in terms of buprenorphine, I have just seen a huge difference in access between a state that did have expansion and a state that didn't. And just some of the numbers from Kentucky, these are numbers from the year before Medicaid expansion was implemented and then the year after it was implemented. So the uninsured rate for opioid-related hospitalizations dropped 90%, and then there was a 700% increase in Medicaid beneficiaries using substance use disorder treatment, and that was primarily buprenorphine with some counseling services, which is required in Kentucky. And so you see that, I do not want to coerce anyone into treatment, but you can see if you expand financial access, people will use it, which is, fantastic. And I think if you look at the naloxone distribution through harm reduction programs, that is success of what folks what folks will do. And so if I look at our numbers from East Tennessee in 2020, we distributed about 100,000 doses of naloxone, and 3,500 of those doses were used to reverse over 1,500 overdoses. And that's one program in one city. And in 2020, we were closed for a few weeks for COVID. And then we were all scared, of course, like everyone else was. And we weren't doing a great job collecting data last year. But still, it shows that our participants, reversed 1,500 overdoses, which is many more overdoses than first responders in our city were reversing. And so I just want to, note when it comes to thinking about Hep C prevention and treatment, the amount of mutual aid and unpaid labor within communities of people who use drugs is simply astounding. There's stereotypes of people who use drugs as only having toxic relationships, of being unable to care for one another. But naloxone in and of itself shows that is simply untrue. And so I want to acknowledge that unpaid work, but also moving forward, I encourage people to think about ways, whether you're thinking about Hep C or HIV or preventing overdose deaths, how do we support that labor? How do we support those communities? And how do we approach those communities to understand what they say they need? Also, I think we can definitely learn some lessons from permanent supportive housing and housing first models. If you're not familiar with these, I encourage you to look it up, but it's really focusing on providing housing first without a litany of requirements in order to get housing, including sobriety requirements. So I think what we've learned from this is if you provide services people say they want, those services will be more effective in terms of making people lives better than if you provide them services you think they need. And we have all the evidence there from housing first models. And I think it also shows us, and I don't want to get into cost effectiveness too much, but I think sometimes you have to bring that up when advocating for these things, because sometimes that's the only thing people will listen to, is it is more cost effective in the long run to directly address an issue than to continue to deny services and discriminate people based on their drug use or housing status. And I think also when you look at some of the drug decriminalizations efforts across the United States, there's also some lessons learned there, and some are good, and I think some are not so great. But one that is, I think, a positive thing is that wide-scale policy change can dramatically affect the social landscape incredibly quickly. And if you go into areas where things were criminalized and then not criminalized, you see the cities and the states change, and oftentimes in positive ways and sometimes not. But I would not argue that the problem is with decriminalization. The problem sometimes is with how it's decriminalized. So when thinking about changing large-scale policies, I think equity has to be at the forefront, or the same people who usually benefit from policies will continue to benefit. And we have some areas in the US right now where people are making gobs of money with cannabis, and in that same locality or that same state, people are still sitting in prison or jail because they were involved with cannabis, and that is not equal. And we know that the people sitting in jail are more likely to be poor and more likely to be Black and brown. So again, with these big policy changes, we have to be thinking about equity. Okay, so I think that is about my time, and I would be happy to answer questions via email, or I think there's also a system they have set up for me to answer those questions. Also, I've been talking quite a bit about East Tennessee because that's where I am now and have been for the last few years, but I also did quite a bit of work in rural Kentucky looking at different types of substance use treatment, and have a book about that. So yeah, I hope to hear from anyone who has questions, and I'm so happy to be sharing our work here. Thank you.
Thank you so much, Leslie Marie. Let me just clarify for the audience that we won't be able to take questions in real time today, but you did see Dr. Buer's email address, and if you'd like to follow up with her, as she indicated, please do so. As you know, our last plenary speaker was scheduled to be Kelly Hans, but as Daniel Raymond mentioned, something came up at the last minute that prevented her from participating. But we are extremely fortunate that Daniel Raymond and Mr. Nick Voiles, who is the executive director of the Indiana Recovery Alliance, have agreed to step in and are going to share with us through a one-on-one conversation some individual perspectives related to the intersection between hepatitis C infection and substance use, particularly as it pertains to people who live in Appalachia. So I'm going to turn it over to these two gentlemen, and we're all looking forward to what you have to say, guys.
Thank you so much, Ron. And Nick, thank you in particular for being willing to step in. I know that I always appreciate our conversations, and I know that this will be helpful for the audience. So I guess I wanted to just start. So we've heard from Dr. Deshali about the broader epidemiological view, and Dr. Buer from the kind of structural and policy view. In terms of what's going on with hepatitis C and people who inject drugs, what are you seeing? And I guess, maybe start with your vantage point in Indiana with the Indiana Recovery Alliance, but you also work nationally, and I know that you talk to a lot of colleagues about what's happening with drug use, with overdose, with viral hepatitis, including, some really interesting projects that Urban Survivors Union partnered on in terms of the More Than Tested Cure project. So what's the view from your vantage point?
Yeah, Daniel, I'm glad to be here, and I'm especially glad to talk about it in this context. I'll first start that I was infected with hepatitis C, tried to get the cure, and could never get cured, so my community cured me. So I never received a medical angle. It was just through some friends in my community cured me. So that kind of gives me a particular vantage point, especially being here in Indiana. Just recently, the Scott County Syringe Service Program was shut down, or it was slated to be shut down in January of 2022. Through a lot of robust activism and help and data, the Austin City commissioners have now gone ahead and voted yes for there to be an SSP in Austin City. So that during all the turmoil of these attacks and these SSPs shutting down, that's one small win in a vantage point where we just constantly feel under fire. Hepatitis C is something that I personally understand the ravages of, and especially in places like Indiana or rural West Virginia or North Carolina or Georgia or any of those places. It's one of those things that's hard to even quantify because people have spent so much of their time trying just to stay alive. Things here are slated. It's a constant feel of people. Now that the boomers are cured, why should people care that the only people who are new infections from people who use drugs? And even nationally, it's looking that way. And it's seeming more and more we have partisan politics playing a role in the curing of a disease. There are no new stellar breakthroughs. We have not, trampled into dried blood spot testing. We are not making innovations. Things from my vantage point look very stagnant and very bleak. Indiana is the #1 state in the nation for acute hepatitis C infections. And nothing's being done. The same things that have always been done. We got rid of barriers. So it's bleak in that sense. I mean, not only is it bleak, but it doesn't seem to look as if we're making our point well enough or if we're pushing through.
Yeah, thanks. I hear a lot of that as I talk to people, especially on the patient side, the frustration about where's the sense of urgency. And I think about what you said at the beginning, that your community cured you, and thinking about what that looks like in practice. that our colleague Louise Vincent, who is also on the planning committee for this event, did a storytelling project not that long ago. And I felt like I learned a lot from her about how the stigma around hepatitis C is interwoven with gender-based stigma around substance use. And that interplay that sometimes I think when we talk about stigma for diseases like HIV, sexually transmitted diseases, or historically cancer, we think about it as a somewhat disease-specific stigma, that this disease is scary and people are scared of it. But I think the hepatitis C story is a little different, that the stigma around hepatitis C might not solely be, but is so heavily intertwined with stigma around injection drug use, and that manifests in different kinds of levels. The kind of structural or policy level that you talk about, that why should anybody care if they don't care about these people who deserve punishment or didn't need to take this risk, but also internalized stigma that people inherit or internalize this sense that, well, maybe I'm not worthy of a cure. If that's what the message that I'm getting from everybody, then maybe this is just my lot in life. Maybe this is just my fate. And I'm wondering if you have some thoughts about how that plays out.
Yeah, I think one of the things I learned from a lot of working. So there's a program that's going on right now for 3 different agencies in different locations. It's called the More Than Tested Cured. It's been going on for 4 years. This is the 4th year of its iteration, and it works with helping people use drugs and people with hepatitis C, finding the barriers, breaking the barriers, but more than that, finding stigma and breaking down not only the stigma that's placed from external forces, but the stigma that's placed in internal forces. And that's kind of like when you're talking about it, like we worked on disrupting narratives, disrupting social narratives around hepatitis C. And what we found out was that most of the time, it wasn't so much that external pressure was there, although it's kind of a lizard brain societal feeling that because people who use drugs have put themselves in that place and that they don't care about their health, and that people whose drugs are just winging it and we can get a cure, so why do we care? It puts a real hard bias internally as we parrot that back to each other and then shove that stigma onto each other. And it's a strange situation where, just the same as with these things with the drug war, we tell ourselves things like, prison saved my life, or, I'm glad if I wouldn't have gone to rehab, I'd be dead. These things that put an onus on an untrue equation. You might not have been dead. You might have died if you didn't go to prison, although you might have had a wonderful life, not had a record, not had a lifelong dealing with the carceral system, which will plague you way worse than anything else you could ever have, And I think until we're talking about treating the whole person, when we focus, especially at when we're talking USU and IRA and NCSU, we focus on the whole person. You know what I mean? Like you have to look at entirely what's going on before you can even begin to treat hepatitis C. One of those in the program you're talking about in the story sharing, we realized that someone will come up with an idea. Hep C is transmitted via sexually, through sex. That'll translate when we give them the test results, if we're not careful, to coming home and bringing that to that person's partner, who will then say, you must have had sex with someone else. What have you brought home to me? So not only do you have the internalized stigma of this person knowing they're going home to deal with this, but then you have it parroted back and ratified by the person they come back to. And this is just one idea of the things that the cascade of stigma that rolls through. And we talk about stigma all the time, and we don't really understand that it's like mental health. It plays a huge part on what we do in this world, how we move, who we are. As a person who uses drugs, I don't understand some of the healthcare. We're trying to solve this problem through a healthcare perspective, when really it requires something that people might have to get a little dirty. They might have to have uncomfortable conversations. They might have to truly meet people where they're at. a lot of us people who look at the situation with HCV and they go, well, it takes so long to get cured. I'll figure it out later. There's a cure. I went in there once to get a test and nobody, they never got back with me, or it takes 2 weeks to get another test and they walked away, and it's only through the people we've been able to touch with stuff like the narcofeminism story sharing model that we used with More Than Tested Cured, and the social media we put out because of that some people are starting to push that away. Then you get into society and things with policy updates, and you see people crushing SSPs, the bill in West Virginia, the attempted bill, 334 in West Virginia, bill 607 in North Carolina. The attempts are, what happened in New Jersey, of all places. That internalizes us to feel like, well, we're not, they don't even want the smallest of things open for us, which in turn makes us think, well, why would I get cured? It's too much of a problem, and that is the lizard vibe that's the vibe we're getting back from society as a whole. We feel like society feels like, we don't care. It's just people use drugs. You're not baby boomers. You're not, this or that. When in reality, we need to be if we treated the whole health of this person and really started to talk about the stigma that's changed their mental health, start to talk about, all of the Maslow's hierarchy and needs stuff, we would get into a place where that person was way comfortable with getting Hep C cure and treatment. They could even maybe wait a little bit. But you can't expect someone in chaotic use to care about that if they don't even feel like you care about it. They just feel like you're checking a box.
Yeah, thanks, Nick. And I think what you've laid out is a really kind of elegant exposition about how stigma at the structural level plays out at the interpersonal level, plays out at the internalized level, and that we often talk about, let's do a little, let's do a poster campaign to destigmatize this or that, but we need to be talking about this simultaneously at these levels, and that stigma is a social determinant of health. I wanted to turn a little bit to kind of think about how to fit hepatitis C into the current work and strategies and policies that are happening around overdose. So today, CDC released its updated provisional data for the most recent 12 months of overdose deaths. And they have been releasing this month by month. I think the latest one is May 2020 through April 2021. And what they reported was 100,000 overdose deaths, which feels monumental, on top of the hundreds of thousands of people that we've lost over the last 20 years. And while they didn't have demographic data yet, they were seeing these increases in overdose in virtually every state, significantly heavy increases in two of the top three states were Kentucky and West Virginia. So there is a sense between the COVID pandemic, between overdose, and between the ongoing grinding toll of incarceration and homelessness, that the people most vulnerable to viral hepatitis, to hepatitis C, people who inject drugs, are under siege on all fronts. And, that kind of begs the question, you talk about kind of addressing the whole person. What are the ways that people who might be in an emergency department, they might be a recovery coach, they might be a harm reduction outreach worker, but they do have some kind of touch point, some kind of access to people who are contending with multiple competing risks to their health, their dignity, their personhood? How do we kind of take that complexity, but put it into practice?
It's good, Daniel. That's really, I hate to say this, but we have to go back to the training. People are not trained. I've seen many people who give test results, who deal with staff, and the trainings are usually done by some place that has had, input from people who use drugs. But we are never at the point where we are creating our own stuff. We're trying to at USU, but it's kind of like a chicken and the egg thing, It's like every time I come up with this question, what could I tell them that would reach me better? What could I tell someone that would turn the tide? And there are simple things that are like knock you on the head. Why aren't we doing this? Like dried blood spot testing, point of care, RNA confirmatory testing, sending people with a little bit of, hope out there in some way that maybe getting the cure within the same time that they're sitting here. But before all of that, we have to look at how those people are being treated, and it's not uniform. It's not like we have a uniform training across the lived experience world or across the healthcare connection world. We have best practices and we have, these things that people trying to get there. But if we're going to start addressing people who use drugs and we're going to start consider them, we're going to have to go all the way back. We're going to have to go back to the training board. Training wheels on. Okay, how do we do this? This is a new world. We are not dealing with heroin anymore. We are dealing with fentanyl. Your average person used to use dope. They'd go out, do a shot. They probably wouldn't overdose. Even long into their storied history, they might have maybe came close once or twice. You're now looking at roulette every time. You're looking at stuff inside of these drugs that is just unreal, like, the xylazine that almost killed Louise, Until we start talking about putting a person there, training them to deal with the whole health first, so we get, I guess, let me simplify this way. We send a harm reduction straight out worker to a place. They've been taught harm reduction 101. They've been taught medical triage. They've been taught, confrontation de-escalation tactics. They've been taught how to test and hopefully maybe how to provide counseling after the test. That's rare, but sometimes they do if they're testing for HIV or HCV. So we've already moved into this place where we haven't talked about, have you made that person comfortable? Have you met them where they're at truly, not just, physically? Then we haven't talked about, have you addressed the person's other needs? This person may be in chaotic use. They may need housing. They need this. They may need that. You might not know what's going on. Maybe they're in an absolute craze because they just lost the person they loved and they don't know what to do. So the answer is we have to go back to the training of the people that are out there, which is going to be hard because most of the stuff is hard ingrained. If we trained right, and if we had things like point of care testing, and if we had true decision making, the training done and created by people who use drugs, it's the same thing with cancer. They were having a really hard time with cancer and the treatment of cancer and all this. And there was lobbying by people to get people who had lived through cancer to help. And they only turned the tide at that point because most people, now cancer education is the way that we deal with people who are having cancer is a whole different world, because those people had the input into directing the care, into teaching the people that give the care, and until we do that, we're just spinning a wheel saying we got some representation for people who use drugs and we check that box,
Yeah, thanks. And that makes me think, I know I heard from my colleague, a member of MHR's Voices for HEP Advocacy Network, Deb Grainer, that Kentucky had a meeting yesterday to start, they're planning for HEP-free Kentucky. And a lot of states, and I know, Nick, you were involved with this with Indiana's HIV and hepatitis plan, are going through these planning processes. So I guess I want to give you a moment. As states are moving towards developing viral hepatitis elimination plan, what is your elevator pitch for engagement and meaningful consultation and input of people with lived experience, people who use drugs?
The idea is that if you want, I wish I could say this statement about the bowl and the steak, about the, the idea is that in our plan for Indiana, what we did is it started from a plan that began with Dan Big and Louise. And it created, and the whole idea is it needs to not just include people with lived experience. It has to be centered and directed by people with lived experience. And this is a hard thing for healthcare to get a hold of. It's a hard thing for the state to get a hold of. Nobody likes to give up their power or their whatever. If you are going to have a viral hepatitis elimination plan, you need to go to the people. And with viral hepatitis, it means not just drug users, but people with lived experience. You need to ask them how you can do this thing. Then you need to talk with healthcare workers and go through there. But it has to be led and directed by people who use drugs, current people who use drugs, and people with lived experience. I would also say that while I have just a couple minutes left, there is no moving forward unless we change our cascade of care. If we do not find a shorter time window to test, this will not happen. You know, we've moved mountains with every other medical event we needed to. But the one that affects drug users the most, we do nothing. Oh, we got a cure. That's okay. Well, these people aren't getting cured or they're reinfecting because a simple problem you could fix. You ask anyone who understands hepatitis C or understands any of this stuff, the option will get them tested and cured quicker. And that's what I would say. I mean, I can't pound that drum enough, Daniel.
Thanks. No, thanks so much, Nick. And I think we're going to carry a lot of these themes that you've raised, the complement what we heard from Dr. Viewer and Dr. Deshali, into the conversations for the rest of the afternoon. But I'm going to pass it back to our moderator, Ron Baldessari, now.
Thank you. I want to thank both of you guys. You did a great job of really underscoring the importance of meaningful input and how we need to move beyond tokenism if we want to be able to truly meet the needs of these audiences as they express them, which is what Dr. Buer told us. It's not what we think people need, it's what they tell us they need. So great job. I want to thank all of our panelists for really setting the stage. We are now going to take a 10-minute break. We will reconvene promptly at 1:30 for an excellent panel presentation. So please don't be late. But in the meantime, during the break, if you have an opportunity, by all means, visit our sponsors exhibit. You can find those exhibits under the sponsor tab on the virtual platform. So we'll see all of you back here again at 1:30. And once again, thanks to all 4 of our plenary speakers for an excellent job. Welcome back from the break. And we've put together a very interesting panel of 4 experts who are each going to talk about a different aspect of systems of care for people who use drugs. Each of the, and I will be introducing them momentarily, each of the 4 presenters will have 10 minutes to share from their perspective some of the challenges and perhaps more importantly, opportunities and strategies to overcome those challenges within that particular system of care. And then following each of, after we hear from all 4 of them, we're going to have a moderated discussion. Participants, you'll be able to submit your questions in the Q&A box, and I will then direct them, your questions or your comments, to a particular panelist or 1 or more panelists. So let me just briefly introduce all 4 of them now. We are going to first hear from Leanne Levine, who is a family medicine specialist with Valley Health in Huntington, West Virginia. And she is going to be speaking on hepatitis C treatment for people who use drugs. Then we will hear from Dr. Kelly Cooper, who is the Director of Addiction Services at Norton Healthcare in Louisville, Kentucky. And Kelly will be talking about medication-assisted treatment for people who use drugs. Then we'll hear from Ms. Michelle Mathis, who is the co-founder and executive director of the Olive Branch Ministry, which is an interfaith harm reduction program in North Carolina. She's going to be talking about harm reduction services. And last but certainly not least, Mr. Terrell Gleason, who is the founder and executive director of Advocacy House Services in Greensboro, North Carolina, who's going to be speaking on the topic of overdose prevention efforts. So again, we're going to hear 10 minutes from each of the 4, and then please submit your questions in the Q&A, and I will direct them to the panelists. So let's begin by hearing from Dr. Levine.
Welcome. Thank you for inviting me. First of all, just give you a little bit of background. I'm a graduate of the West Virginia School of Osteopathic Medicine. I attended family medicine residency through WVU in CMC Charleston. I have been in practice approximately 20 some years. I'm currently with Valley Health, and we have been around serving our community for 40 some years. We've got over 38 locations, including WIC and school-based facilities. And we have specialties from family medicine, internal medicine, pediatrics, OBGYN, ENT, optometry, dental, behavioral health, including psychiatrists and psychologists, and clinical pharmacists, as well as having pharmacies in several of our site locations. We serve over 75,000 underserved, insured and uninsured patients per year. And we have 2 locations where we serve over 400 plus medical assisted treatment MAT patients. And that's what I'm here to talk about is our MAT program. And being in the Huntington, Charleston area in West Virginia, we are leading in numbers with opioid addiction, substance abuse, and our Hep C. And so what I have started, I work with our MAT program in the Huntington location. And I've been working with MAT for 6+ years now. The Hep C, what we try to do is capture the Hep C at the time of a new patient coming in for medical assistant treatment program, the ones that are asking for help. We run our lab work, and then we try to get them situated in the state of West Virginia. One of the biggest barriers is that we currently cannot treat as a family physician Hep C without having a collaborative for a GI specialist, gastroenterologist, or infectious disease. So that is one of the biggest barriers to treatment, is because patients, we lose them trying to refer them out. And the overwhelming with the pandemic and the Hep C, trying to get them in to see infectious disease right now in the hospital when COVID is overwhelming is 6 months or more out to get seen. So I have been wanting to take this on because I see the importance of trying to capture the Hep C treatment at the time of visit with us, not only in the primary care setting, but also in my MAT clinic. So Dr. Kara Willenberg, who is infectious disease at Marshall University, has graciously agreed to collaborate with me. So what that entails is the patient sees us in our MAT program. We identify positive Hep C patients, and then I see them in our Hep C ID clinic at that time. And we do the further, in the state of West Virginia, not only do you have to have a collaborative, but you also have to have 2 positive quants 3 months apart. And I think that is also a little barrier to treatment, having those 2 quants 3 months apart. But that's the criteria for West Virginia for Medicaid and Medicare for approval. So we do also have to have the liver ultrasound. We also order FiberSure to check for fibrosis prior to treatment. Most of our patients are more than grateful to be treated within Valley where they feel comfortable. We lose many, many patients when we refer outside. So we've been very successful with our treatment. Typically, we treat with Mavorite, and typically that is an 8-week treatment. And the patients are usually all non-detectable within that 4-week mark. So the treatment options for the Hep C is great success. But like I said, the barriers include some of the West Virginia criteria of family practice not being able to treat without a collaborative on board, and also having that second quant 3 months apart we lose some patients. So that's where we are working with state legislation, trying to get some of the criteria lax a little bit so we can try to get this a little bit more under control. Like I said, the majority of our MAT patients, when they come into our program, are positive Hep C and have not had treatment. Like I said, we provide that care at Valley Health, and we are trying to get more treatment easy accessible. And like I said, also another barrier is the liver ultrasound. We had to refer that out. Whereas if we could just go off the FiberSure to check for fibrosis and liver damage, that would also be easy access for treatment.
Thank you, Dr. Levine. Now we'll hear from Dr. Cooper.
Thank you.
All right, I'm not muted, correct? All right. So I do have a couple of PowerPoint slides, so bear with me. I know many of you are not PowerPoint fans, but so I'm going to talk to you more specifically about MAT in the persons who use drugs population. And I wanted to first highlight, if you can move to the next slide. So this was actually something that really struck me recently, and I want to bring this up. So this is a national survey that's done every year through SAMHSA, and it basically looks at the numbers of people who in the past year have a substance use disorder, and it just basically gives us the numbers on these. So in 2017, if you'll notice, there's about 20 million folks, adults that had substance use disorder, and about 35 plus that had a mental health illness. Well, if you move to 2020, those numbers for substance use have doubled. So, this is just staggering to me. We see it on the ground, but the fact that in 3 years, our numbers in the millions have doubled to an extra 20 million in the last 3 years is staggering. And then if you notice, the mental health issues have also blossomed to some degree, but not nearly as much as the substance use disorders. And if you move to the next slide, this is an interesting slide also because it tells us basically there's a lot of people based on the survey that feel that they don't need help. In fact, 98% of people with a substance use disorder feel they don't need help. And then about 2% feel that they do and seek services for that help. And only about 0.5% of those patients total get treatment. So, we've got kind of an uphill battle in a lot of respects here. And I just wanted to put those numbers out because I think they're really important. Next slide. Okay. Next slide. Thanks. So in terms of MAT, again, this is medication-assisted treatment. And I want to talk a little bit more about what that is, just so that everybody's on the same page. So what it is it's specifically medication substitute for whatever, specifically for opioid use disorder. It's a medication substitute to help with their cravings and stabilize their brain so that they can move on into recovery. We use 3 different medications for that. One is buprenorphine, Suboxone, Subutex. Those are examples of that. And that's a partial agonist, which basically means when it binds to the brain, receptors in the brain, it turns those receptors on about 40%. The other side of the spectrum of that is methadone. Methadone is a full opioid agonist, which basically means it turns those receptors on 100%. So buprenorphine is in and of itself a safer class of opioid medications than a full opioid like methadone or fentanyl or all the other kind of illicit or other prescription opioids. The other is the antagonist, which basically is naloxone and naltrexone. You've heard that called as Vivitrol. That's the injectable form. And that really blocks the opioid receptor. So that's really what we're talking about in terms of the medication part of MAT treatment. But, we understand that there's a range of goals, both with the patient, with the provider, with family members, from minimizing harms on one side to, abstaining from all substance use on the other side of the spectrum. But really our goal is that if we can maintain long-term recovery with or without medications, whatever role medications play, we want to try to achieve that. And I'm done with the slides, so. Okay, we can shut off the slide set. So, all right, so I want to talk to you a little bit about why why medication-assisted treatment is a big thing. Well, it works. We've seen, we have a lot of data out now that shows that it's very effective. It keeps people from using illicit substances. It keeps them from using risky substances. It addresses their withdrawal. It decreases their withdrawal, their cravings, and it helps to stabilize their opioid dependence issues. It also decreases mortality, because when they're engaged in care, their actual mortality goes down. So that's a big plus as well. The longer we can retain patients in care, we see that the better that they do in all of these categories. So I want to talk a little bit about barriers and challenges around MAT. So access is really the big thing. Different states have different rules around prescribing of buprenorphine or Suboxone, but as well as methadone, that really hasn't changed. But so, will insurance pay for it? If they don't have insurance, how are they going to get the medications? How are they going to get the treatments? Also, challenging populations. Rural folks have a lot less access to MAT than the more urban or suburban areas. People who are homeless, they don't have a lot of access to MAT as well, or people in transient housing. There are also significant pharmacy barriers. And I know in Tennessee, there's pretty significant pharmacy barriers for prior authorizations. And then, I've also had pharmacists who will refuse to fill prescriptions. And, there's a lot, that's kind of a loaded issue, but stigma certainly plays into it. There's also medical issues, and we've talked a little bit about this already on the program, but there is a lot of a lack of expertise, a lot of lack of knowledge around addiction, around substance use in general, that's rampant in our medical community. And it tends to, in the healthcare system, we tend to isolate it. And we really need to embrace it and learn how to handle it wherever a patient presents with a substance use problem or an overdose issue. So the other thing is, in the medical community, there's a fear of legal issues around prescribing buprenorphine. So I just want you all aware of that. I'm trying to recruit a lot of primary care docs to prescribe, and there's a lot of fear around that. In addition to some of the lack of knowledge and time issues, et cetera. We've talked a bit about stigma. It is alive and well, unfortunately, and not just in the medical community, but in other areas of our society, the legal community, the law enforcement community, and just the community in general. We've also talked a little bit about the stigma, the internal versus external stigma. And I will tell you, I've had patients who have come to me crying because they were physically present in the clinic and said that everybody they knew would pretty much disown them if they knew that they were seeking help for their substance use disorder. And, it really broke my heart because, there's more than one way to solve this problem or to begin solving this problem. And for somebody to be at their last ditch effort to present to an MAT program because of the stigma that's been internalized from the external people is really, really a barrier that we have to try to work on. There's lots of myths around MAT. So those myths get spread and perpetuated quite a bit in the community, whether it's in the community of people who use drugs or the community at large, including the medical community. So we have to dispel those when we can. The increasing prevalence of co-occurring problems, especially mental health disorders or mental health issues, is a big challenge to MAT and people being even successful in MAT. There's a lot of system issues, especially siloing of care. We talked about treating the whole person, and really that is what we need to do. We need to come to a point where we can address the entire person and not piecemeal that person out to all these specialty areas. So that's important as well. In terms of the co-occurring issues in not siloing, we have behavioral health departments and medicine departments now that are starting to merge addiction medicine, psychiatric care, and psychological support. And we're also starting to pull in peer support as well. So I think that's an evolving area, but also a very, very important one. In terms of best practices, we've got some evidence out there that shows that MAT is really beneficial for patients, and keeping them engaged in some level of care whether it's through harm reduction programs, outreach programs, or MAT. That's the big way to pull people in. And then, us working in terms of the medical community, working on a therapeutic alliance with patients, it's really, really important to know that you care about what happens to them and make sure that they know that. Open access, co-location of services, one-stop shopping for this population is absolutely best, whether it's hepatitis C treatment, MAT, et cetera. That's really important. We're working on ED bridge clinics or bridge programs where a patient can present to the ED and then immediately get on, if they do have an opioid use disorder, get on Suboxone then. And then the other big piece, I think, is building the evidence. And, harm reduction is relatively in its infancy in the United States, not so much in other countries, but we really need to build the evidence that this matters and this makes a difference and it changes outcomes. So I think that's an important piece moving forward for, anybody in this space. And lastly, I would say that building a culture and a community of recovery and reconnecting with people is an absolute in terms of, and it's not just, medical, it's just the entire community. We need to do better to reach out and accept and help people move forward, and recovery is okay. Let's support people who are trying to move forward in that. Thank you.
Thank you, Dr. Cooper. We'll now hear from Ms. Mathis.
Good afternoon. I'm Michelle Mathis, Executive Director and co-founder of Olive Branch Ministry, a faith-based harm reduction agency that covers 10 counties in the Foothill Piedmont area of North Carolina. To give you kind of an idea, we go from the Tennessee-Virginia border down to the South Carolina border. There's almost 2 hours and 40 minutes from our northern tip to our southern tip of the geographical area that we cover. And I say that because all but one of our counties is considered rural in where we serve. So there's a lot of distance, but there's also a lot of communities that we cover with harm reduction services. For those of you who may not be familiar and may need a brief recap, harm reduction refers to policies, programs, and practices that aim to minimize negative health, social, and legal impacts associated with drug use, drug policies, and drug laws. It's not just day-to-day operations, but it is also a social justice movement, really centered on the rights for and the voices of people who use drugs and who engage in sex work. And I think that's super important, that meaningful engagement with people who use drugs is really key to harm reduction. And there's a lot of different ways that harm reduction is carried out. Things like syringe access, overdose prevention, MAT, medication-assisted treatment, medication-assisted recovery. That also is a form of harm reduction, as well as being able to treat people for different types of diseases. Housing first, wound care, things of that nature. And every harm reduction agency looks different. I want to talk briefly about what barriers we see here in rural North Carolina, rural Appalachia, to harm reduction. and then talk about how we have been able to cross some of those barriers or reduce them. The first one for us, as I mentioned, because of our geographical coverage, is lack of transportation. We have 3 fixed site locations. They're an hour apart from each other or more. So if you think about that, if someone doesn't have transportation, and in many of our rural counties and rural cities, there is no public transportation, that then requires to have mobile volunteers to be able to go out and deliver services. People can't walk, if it's an hour by car, they can't walk to where we are. And like I said, most of the time a bus or even an Uber is not available. We have higher poverty rates in rural Appalachia. And so that prevents people from being able to seek other types of care, maybe be able to go to a local pharmacy to purchase syringes if they're lucky to find one who will sell them syringes. The higher poverty rates also is a barrier for people receiving regular medical care, being able to receive things like food, clothing, shelter. Because we are rural, we have a lack of anonymity and confidentiality. And by that, I mean our programs in North Carolina, you can enroll in syringe access and be anonymous, and we do keep our information confidential. But when we're doing rural outreach, everybody, including their mom and them and their neighbors, or maybe community leaders, know who pulls into your driveway. They know if you're meeting somebody in a fast food parking lot or in the parking lot of a big box store. Everybody knows everybody in these little communities. And so you're never without a set of eyes possibly seeing what you're doing. And once somebody knows that you're a harm reductionist or knows what you do, then they make assumptions because of the shame and stigma on why you're meeting with a particular individual. We also, as I believe Dr. Levine and Dr. Cooper mentioned, we have a low health literacy in rural Appalachia, and there's a lot of cultural bias against brain health treatment. I say brain health because we don't have mentals, right? We have brains, and this is a physical disease that affects our brain. So that plays into people not wanting to seek care, people not understanding truly the ramifications of not seeking care. And then the cultural bias. Well, you should be able to do this on your own. We're tough. We've survived so many things. We should be able to do this by ourselves. And so that shame and stigma around people actually seeking care is a challenge. Then we also see in faith-centered communities, because again, we're in the South. And so a lot of our rural communities, their communities are centered on, certain faith beliefs. So we have the moral issue that is a barrier to care. Is it a moral failing, or is it scientific as to why people use drugs and then become at risk of things like HIV and HCV? That then in turns to a barrier of the conversation around enabling. Are we enabling people to continue in what is perceived a negative lifestyle? And then finally, unemployment or non-standard working hours makes it difficult to receive care. If you're unemployed, again, that plays back into poverty. But if you have non-standard working hours, if you're working third shift and you're sleeping during the day, then that may be a problem. Or if you're working, during the day and you're working a 12-hour shift, you may not have availability to seek harm reduction services because they may be only open during standard business hours. So we have a lot of different barriers that play into why people can't access harm reduction services. But we also have some solutions. I will share with you what we've done at Olive Branch Ministry. The first thing we like to try to do is think outside the box. We realize that the faith, for us, even though we're a faith-based organization, we say faith is our why, it's not our what, so we don't evangelize. We simply let our faith be our motivator as to why we do what we do. But we know that that's a tough conversation to have with folks around faith and handing people syringes at the same time, or providing overdose medication even. So we partner with groups like the Humanist Alliance, or with the local Atheist Association, and they actually have partnered with us and are some of our biggest supporters. And that has been really helpful. One, because there's stigma against us as a faith organization. People may not trust us, but that has helped kind of change the way that our community sees us. But it also then allows folks to have access to our services without that having a theological conversation, right? They know that that's possible to access our services that way. Then the stigma and negativity around syringe access programs. Olive Branch was doing syringe access underground for a number of years, as many of us in North Carolina were, before it became legal in 2016. We had agencies that would partner with us and allow us to use an office. For example, we had an MAT clinic who said, we know what you're doing. We can't acknowledge what you're doing, but we support your work. So we're going to give you an office and you can hand out naloxone. But what we want you to do is everybody that walks into that office, you shut the door and everybody walks out with a brown bag. We're not going to ask what's in the brown bag. Our staff is not going to ask what's in the brown bag, but we want to support you in the work that you're doing. And so that was a very unusual partnership to have with an MAT clinic who knew that we were actively engaged in syringe access. Then we have naloxone and trying to get naloxone to folks and making sure that they have access to that to, be able to reverse an opiate overdose. So we partnered with a local crochet group who makes these beautiful little crochet bags that have reflective thread in the handles. So people can find their naloxone without electric light. They, find it in the moonlight if they need to. This is an unusual partnership, but it accomplished of bridging the barrier between naloxone access actually and also the faith community, because the women who make these bags really weren't wanting to work with individuals who use drugs directly, but they still wanted to help in the process. So it began to start a conversation. And now they ask all the time, have our kits saved anyone? We partner with integrated care clinics. So 2 of our clinics are literally between outpatient counseling services and detox. And we're very much included in the continuum of recovery because of our location. When someone comes out of detox, the first thing they do is get naloxone, and we're able to refer people to detox if that's what they want, or rehab, or to outpatient therapy. We have a peer support that's in an MAT clinic as well. Finally, I think it's important to know that at Olive Branch, one of the things that we recognized specifically around hepatitis was the fact that because of transportation, because of all these barriers I've listed, people could not get to our clinics, but they also couldn't get to a medical clinic. And we have a nurse practitioner who volunteers with us, and he's employed by the federally qualified health clinic in a neighboring community. He's volunteered with us for quite a while. So back in February 14th of 2020, last year, we started a low barrier Hep C testing and treatment program. Since that time, we have engaged 93 individuals. Of those, 74 engaged in actual treatment. We lost a few to care. Unfortunately, we lost a few to overdose. That's a 73% success rate in getting people either they've been cured or in the process of receiving a cure. And we did that by going into people's homes, carrying food into their home, and also testing there. I think that's really important as I wrap up, just to say we meet people where they are in harm reduction, but we literally are carrying the treatment and the testing and the treatment where they are. And that's one way to eliminate the barriers, really, is to carry as much of your services out into the field as possible. Thank you.
Thank you. Thank you, Michelle. We're going to hear from Mr. Gleason next.
Thank you. Hello, everyone. And thank you, Community Liver Alliance, for putting on this summit. My name is Terrell Gleason. I am Executive Director of Advocacy House, which is located in Greensboro, North Carolina. Backing up just a little bit, I am part of the LGBTQ plus community. I am part of the drug using community. I'm part of the hepatitis C community, and I'm part of the HIV community. And what I mean by that is I acquired or contracted hepatitis C from sharing needles in 1988. I was cured from hepatitis C in 2015. I acquired HIV in 1990. So what has happened with us here in Greensboro, North Carolina? North Carolina's approximately 10 million people. We have in the Greensboro, High Point, Winston-Salem area, approximately a tenth of that, which is 1 million people. So we have a little bit of urban stuff going on. And what happened with us about 4 years ago was we acquired a safe space here in Greensboro. And so just a group of us that have HIV, we all came together. We formed a nonprofit. Do we know what we're doing? No. Do we know how to get all this funding? No. We're not clinical, we're community-based. And I'm going to share how that has worked for us in meshing into our community to make some positive change. And before I do that, I'm going to consult my slide. And I'm going to refer to an article that was in the Wall Street Journal this morning. Some others have referred to the CDC information. And as of April of this year, the prior 12 months, there have been 100,306 overdose deaths. And according to the article, that's a 29% increase. 2021 will be worse. And the article says it's being fueled by fentanyl. It says, and part of the reasons, according to the article, is that COVID, has increased the overdose problem because of isolation, complicated treatment for drug users and people in recovery, and that COVID is a draw on the public health resources. All that may be true. But what is also going on in our community with COVID, that is part of the solutions and some of the things that we have done, and then I'm going to go back to where I was, we have a board of 13 people. And we are all living with HIV. We are all either current or former drug users. So we have a community link that is our niche. And so when COVID happened, things that we have been doing within ourselves is the first thing that the opportunity there was for people who use drugs or any other disadvantaged community was our stimulus check programs. A lot of people who use drugs, a lot of people who may be on disability programs, they didn't know how to connect with these stimulus check programs. So one thing we did was we got everybody online, we got them applying for their stimulus checks, and we got that cash flow coming to them. Some other things that COVID has brought to us that we were challenged with before were the rent, utility, and the food programs. We're making sure everybody's getting into that. People hear about it, they don't know how to do it. We'll tell you how. There was also the free transportation programs. And then two other little things that have come out of this COVID that I think have been good for us and Advocacy House and our community members are the Zoom connections and communications and telehealth. Those are being brought to the community. We're working hard to get people away from being fearful of that because it's a connection. And that is the thing that we have been working on. We all know the barriers. We all know the challenges. We all know the internal, external stigma. So what we have done with ourselves, and it started with us, with this space back in 2018, we got this dilapidated old house. A benefit factor has let us use it. The community came in and took it over. It's on a ½ acre. It's an old 1,000 square foot house. It's got 5 bus stops near it. It's a 1/10 of a mile from Interstate 40. So the community came together and this became our safe space. We've had some overdoses within our community and their ashes are on the ground at this safe space. We also implement healing justice. Healing justice is a form of therapy that connects one to caring for things and to connecting us to our earth and our ancestors. And one other thing about Advocacy House and our 13 board members, we're 85% VIPOC community, and we have over 300 years of lived HIV experience. And so what's going on with these community connections? We worked on connecting with ourselves. We worked on, we got to have connection. Who do we talk to? And so with these community connections, we've taken our lived experiences, whether they're lived experiences with drug use, with hepatitis C, or with HIV, STIs, or just pure discrimination. So then what we've done with our community is we worked on our language. Everybody who has been diagnosed, being treated for HIV, they know clinical language. The clinical language comes down from the CDC to the health departments, to the providers, to people who are receiving care. So what we have done with other advocacy organizations is created a community language. No, we're not infected. We have HIV. No, I'm not an addict. I use drugs. So what we've learned through community language is that brings about less internal stigma and empowerment. And so with this empowerment, I'm gonna be honest, I'm a loud mouth and everybody around me is a loud mouth. We got a lot to say. So let's take our time that we have to say that and use it most effectively. With our community connections, our lived experiences, and then learning community language, teaching it to each other. In the HIV world, and we're trying to bring this to the drug using community, we have some tools that go way back to ACT UP. And one of them is the Denver Principles. And that is where we honor ourselves and validate ourselves. Another one is MIPA. It's the meaningful involvement of people with HIV and AIDS. And another one is GIPA, the gainful involvement of people with HIV and AIDS. The drug community needs this. The drug community, using community, we need a language. We need some tools that people on the ground can hear, people in the clinical environment can hear, because this brings us together, and together as a force, we're powerful. And then those voices, once we're trained, we can educate anybody. And we really love not lobbying, but educating our political leaders. You go to talk to political leaders, and they've never met anybody that maybe has had hepatitis C or HIV or is a functional drug user. They don't know of such a thing. So moving on, because I'm running short on time. So our community connections, our lived experience with our community language, we're talking about this reducing stigma, especially internalized stigma. We've gone out, and with that, we've gone out into our communities. We love to get as a group and go in front of the Civil Rights Museum or go over to A&T University or go somewhere. And as a group, we start talking about sex and drugs. Now we're in Greensboro, has a population, we have 8 universities, and that's not counting any of the strayers and online stuff, but we have 8 universities here in Greensboro and a student population of about 50,000. So what happens is we're out there as a group, the support of a group, talking about sex and drugs. We get the community's interest because we think it's fun, and it is. So what have I missed? I'm running short on time. So the main thing we're doing here really is we're connecting with the community. We feel like a lot of these issues and challenges are people being rejected or, don't do that over here. And so we're just reconnecting. We feel like connection is the opposite of addiction. And so, yeah, that's what we've done. We've got a long way to go, but we feel really good about what we're doing. And thank you, Community Liver Alliance, for including the community conversation into this. And thank you for all of you for being part on the clinical side and being allies and helping us.
Thank you, Terrell. I want to remind the audience that I do have one question that's come in, but I want to remind all of the summit participants that if you can type questions into the Q&A box or comments, and I will direct them to the speakers. So the first question I have has to do with Leanne, with the requirement in West Virginia. Rebecca wanted to know, where does that requirement come from that one must consult with an ID or a GI doc? Can you tell Rebecca where that comes from?
Yes, that is coming from West Virginia Medicaid requirement, which is the majority of our patients is West Virginia Medicaid, Medicare. So with that West Virginia requirement, a family practitioner is not allowed to go ahead and treat without having a collaborative GI or infectious disease stamp off approval of our packet that we send them. Once we get that approval back, so that packet includes lab work, the liver ultrasound, the 2 quants, the FiberSure, they've got their Hep A vaccines, the hepatitis B vaccines. Then we can get insurance to approve, the Medicaid insurance to approve treatment. But that is just a lengthy process. And like I said, if we could open that up and let us family docs be able to treat in our outpatient setting, whether that's in my MAP program or my family practice setting, that would open up a lot more success with the Hep C treatment.
So let me interject a point there that probably most of the audience knows, that in most states, the Medicaid fibrosis requirements, there used to be requirements that someone really had to have severe liver disease before they could even be treated, but advocacy has changed that.
Yes.
What I want to ask you, Leanne, is, are you aware of any advocacy efforts in West Virginia to change that requirement around having an ID or infectious disease specialist doc? Because the one thing you didn't mention is that your state is not rich with these specialties. I mean,
correct.
There aren't that many specialists.
I'm glad you brought that up, because that is a huge problem, especially during the pandemic. So even though it took me about 6 months to even get a collaborative to agree to be able to do this for us at Valley through myself. And like I said, when that pandemic hit, it just threw everything. She is wonderful, but she's infectious disease. So she's in the hospital taking care of the COVID patients. So the delay from the time she receives the packet typically would have been a 2-week turnaround, but now it can be 4 to 6 weeks. And that's really such a delay.
So if I'm going to move on with a question for Dr. Cooper, but if anyone in the audience from West Virginia is aware of advocacy efforts to try to change that requirement, I'd like to hear from them.
I'm sorry. I didn't really answer your question. So we have within Valley talked to several of our legislators. We've brought this to their attention. They agree this is a problem, but yet there's been no change at the state level to reduce that barrier.
Yeah.
But we're still working.
Okay. I have a question for Dr. Cooper, but in the meantime, Dr. Cooper, we have a question from Michelle asking, what changes have you seen within your patient population related to COVID? Both positive and maybe negative impacts.
Yeah, so great question. Thanks, Michelle, for asking that. I've seen, in terms of negatives, I think there's been a lot more severe substance use, and I will say especially alcohol. So, I have a lot of patients that either they have a substance use disorder of something else, and alcohol is now a bigger component. I've also seen a lot of patients use more and different substances. So people who now are starting methamphetamine because they need more energy. People who, aren't sleeping well, so now they're taking benzos, but they feel good on benzos, so now benzos become an issue as well. So I've seen more polysubstance use. I've seen more severe use. I've also seen people who have, on the positive side of things, who have been more isolated because of the pandemic. And in that isolation, they actually didn't have access to a lot of the drugs that they used to have access to, and they've actually done really well. And then the other side of that is the advent and the mainstream use of telehealth now, I think has really changed the landscape for treating addiction, because, you know, I have had patients that would have relapsed many times, but since we were able to get them via telehealth and get them their medications prescribed, so they didn't, because they have car trouble, they have kid trouble, they have COVID issues. You know, to me, telehealth has been an absolute blessing for this, for treating these folks, because, you know, I really think there would have been a lot more and dangerous relapses if that weren't the case.
Okay.
So
I'm going to move us along because we only have 2 minutes.
Sure. Yep.
And a question came in, but that you partially answered about meth use, but one came in that I'm going to direct to Michelle about harm reduction. And Linda wants to know, Linda's saying that we're trying to fight drug paraphernalia laws that make it difficult to get safe smoking and safe snorting kits to the community. How are you handling this in outreach harm reduction efforts? Michelle, do you have anything to comment on in that regard?
Yes. So I believe, first of all, Linda, thank you for that question. In North Carolina, our immunity is very limited, and it only covers safe injection supplies. It does not cover safer smoking or snorting supplies, unfortunately. I personally have advocated now for over 4 years with the Injury and Violent Prevention Branch here in North Carolina, and with the other leaders that be, to change that wording from injection to consumption. However, what we're finding is that we just, you know, having had the battle over nearly basically eradicating syringe access in North Carolina this spring, that we're scared to change injection to consumption, because then that leads to conversations around safer consumption sites, and we could, you know, put all of our programming at risk. So there are some harm reduction agencies that go ahead and give out safer snorting and safer smoking supplies, and let their participants know that those are not covered under the immunity clause. Olive Branch does not do that. And the reason why is when we started doing that, we had people who were very confused, even with a lot of education around the fact that our immunity only covered safer injection supplies. So we made the decision as an agency to not hand out safer snorting or safer smoking supplies. And that's how we decided to do that. But we do know that there are some agencies, harm reduction agencies, that are doing that. We are still fighting for that and advocating for that change in our immunity clause, but it has been a long, hard-fought battle, and something that, even though we've had legal syringe exchange now since 2016, we're still fighting for.
Thank you, Michelle. I'm going to use moderator's prerogative. We have a question that's extremely HIV specific, but I'm going to go ahead and direct it, Terrell, to you, even though we kind of are interested in the Hep C focus today. But Michelle wants to know, with regards to HIV and drug use, what is your top strategy for promoting HIV prevention? So what do you think is the most important thing, Terrell?
Thank you. Thank you. You know, HIV prevention, the PrEP, is really good. And it's really good for drug users. And, you know, there's some PrEP going on around here, some programs that are really popular with PrEP. And this is the once a month injector. Why I think that works really well with the drug community is it's hard for drug users to get into care. If they're into this HIV care, it's going to be easy. I think that's really a pathway to connect the drug using community. And one other thing, and that wasn't part of the question, there used to be a high percentage of people who had HIV also had hepatitis C. But since a lot of us were in care, we got that care when it was first available because we were there. And so, yes, if the PrEP for people that are at risk, that's a great way to connect them.
Yeah. So I'm going to just make a comment about your last point, Terrell. That happened by and large because HRSA, the Health Resources and Services Administration, really put a lot of effort into getting Ryan White care providers to diagnose and treat hepatitis C. But as the clinicians on this call know, we don't have a similar Ryan White program for viral hepatitis in the United States, which is one of the issues. I do have a question that I wanted to ask you, Dr. Cooper. You talked about primary care providers' unwillingness or hesitancy, I should say, to prescribe buprenorphine for a number of reasons, including liability. Are you, I don't mean you just by yourself, but are providers in your state or organizations trying to do anything to promote more primary care providers providing buprenorphine? And if so, what are you doing?
Yeah, so that's one of the things I've been working on the last 2 years, actually, primarily in Kentucky. And you know, there's definitely a handful of providers that are very passionate about it and want to kind of dig in and help fight the fight. But I think the majority of them they have a lot of fears for a lot of reasons, and then they just don't have the knowledge and the expertise and experience to back it up. So it's kind of it's an unknown, and they're afraid. And then you add the stigma to that. Well, you know, now I'm going to attract all the drug using community in my clinic, and then what's going to happen in the clinic, right? So, you know, and what we tell people, we were just actually talking about this today, you know, we had conversations with primary care docs, and they said, well, you know, now we're going to get the drug using population in my clinic. And we're like, they're already there. You just aren't asking the questions to actually know that they're there. So if you don't think you have a person using drugs on your entire panel, that's outrageous. So part of what our goal is, we've been doing a big education push. We've done it through in person, and we've gone to clinics to educate people. And primary care docs, we do like a video education sessions, podcasts. We do a whole bunch of stuff. Oh, we also offer X-waivered MAT training. I will do that personally for them, like every 3 or 4 months. So we're getting more and more people trained. It's just a very slow process, and even, you know, so it's not that we can get everybody X-waivered and prescribing. That is really their personal choice, whether or not they want to do that. But my goal is to at least get them educated and start breaking down the stigma issues. And I work with them on patients. So when I'm successful with a patient, really it's the patient that's successful. I'm really just helping. But if we can be successful with a patient, then these primary care docs can see, oh, this is actually really great. This person went from, you know, a bad situation to now engaging with their family and getting a job and doing all these things. Then I think we're starting to turn the tide of stigma a little bit. And I think we've done that to some level of its success. But again, it's these baby steps that we have to do to just kind of advocate.
Thank you. Michelle, Imogene would like to know how your program is funded.
That is also thinking outside the box. So we are a HEP Connect grantee. And so we are very thankful and blessed for that funding. We also have developed partnerships with our local managing mental health entities. So we have contracts that allow us to provide peer support that also helps fund some of our other programs. But we have not applied for any state funding as of yet, although with the changes in funding availability, I can see that in our future.
Okay, thank you. I have a general question that anyone or all of you can respond to, and it has to do the role of pharmacists was mentioned briefly, I think, by Michelle, but it has to do with the question of, are any of you aware of positive examples of local pharmacists being recruited to help improve the health of people who use drugs, either in terms of their drug use and or hepatitis C? I saw you shake your head, Leanne, so I'm going to ask you to comment first.
Yes, at Valley Health, our clinical pharmacists are very involved. They will come over periodically and do the Narcan training with our groups. They talk about, we also was very active in the PrEP, initiating PrEP and talking with patients about starting the PrEP in the high-risk patients. The pharmacists are very accessible, and I think they are a huge access point for getting our Hep C treatments. You know, we've been treating patients without insurance, getting it approved through the companies, and we couldn't do this without our pharmacists, clinical pharmacists on board.
Got it. Thank you. Any other of you like to comment?
Sure, I have some pharmacy experience. So in Tennessee, the pharmacy experience can be very challenging. I've had patients that I've prescribed Suboxone to that it took them 13 pharmacies before they would actually fill the prescription. There's been a lot of stigma in pharmacies, at least in East Tennessee, from my experience. And then I finally connected with one who is actually in kind of West Knoxville. He actually is a recovering from addiction. And this is like his major passion is to help this community. So it's really great because whenever my patients have problems with other pharmacies, I can send them to this pharmacy, and him and his staff are just totally empathetic and supportive, and he does advocate kind of on a state level in the pharmacy board of pharmacy, et cetera, to try to have appropriate laws and legislation, especially through the Tennessee Board of Pharmacy. So I can't say enough about positive support from pharmacists because it can be a struggle.
So I'm going to share a comment that we got from Michelle, just as an FYI for everyone, who said that the Kentucky Board of Pharmacy approved PharmDs to test for HIV and hepatitis C and prescribe PEP and PrEP, but they don't write protocols, so we need MDs, exclamation point. Let me just, Terrell, I'm going to ask you to give a brief answer because we're at time, but I think all of us understand the importance. Daniel Raymond mentioned this early on, and several people have repeated it, the importance of involving people with lived experience in the development and implementation of viral hepatitis elimination plans. As briefly as you can, what would be your advice for people who want to involve folks with lived experience, either in terms of the Hep C and or drug use, in involving them and coming up with viral hepatitis elimination plans? How do we do that?
We've got to pull them together somehow through the medical community, because people, it's not like the HIV community, we have it. People have viral hepatitis and they get cured. We need some help from the medical community. Y'all know everybody, the advocates don't yet. So if we can connect that.
Okay. So connect those two communities. So let me end by thanking the panelists for excellent presentations and thanking the audience for your thoughtful questions. We are now going to the breakout portion of the summit. As I mentioned earlier, each of you should have received a message about what breakout room you'll be assigned to. You'll have a chance to meet your moderator and talk about issues. We will reconvene. Let me make sure I get the time right here. Looks like we're going to reconvene at 5 minutes after 3 and have brief report backs from each of the breakout groups. So again, thanks to the panelists. Have a good time in the breakout session. Welcome back, everyone. I first of all want to thank you in advance because I know that in 30 minutes, coming up with key recommendations on such a complicated topic is not an easy task at all. And I especially want to thank in advance our moderators and rapporteurs not only did they have to guide the discussion, but now they only have 4 minutes each to share key recommendations with all of us. Want to remind folks that what we're going to do, I'm going to be introducing all 4 of the panelists, and then we're going to hear, the moderators, then we're going to hear from them one at a time. And we'll use the same format. Any questions or comments you have, please enter into the Q&A. I can see them, and then I will direct them to the appropriate person. And the reason we want to have the report back is that we know all of you are very smart and committed people, and you might have been in one particular breakout group. Let's say you were in the harm reduction group, but you have some thoughts about overdose prevention or vice versa. So we want to give people an opportunity to share comments and thoughts. So let's get started. We're going to first hear, again, I'm going to go through all the moderators. Dr. Adrienne Simmons, who is the Director of Programs at the National Viral Hepatitis Roundtable, is going to share the highlights from her breakout group on Hep C treatment for people who use drugs. Then we're going to hear from Mr. Jay Mason, who is the Director of Community Programs at the West Virginia Clinical and Translational Science Institute. And he's going to provide feedback from the breakout group he moderated on medication-assisted treatment for people who use drugs. Then comes Ms. Michelle Rose, who's the Population Health Manager for Norton Healthcare, who will provide highlights from the group who were talking about harm reduction. And last but certainly not least, Mr. Nick Voles, who you heard from earlier in the day, who's the Executive Director of the Indiana Recovery Alliance, is going to share information from his small but mighty breakout group on overdose prevention. So we're going to start first with you, Adrienne. We're anxious to hear what you have to say.
Awesome. Thanks so much, Ron. We had a wonderful discussion in our group. Just as a reminder, our topic was hepatitis C treatment for people who use drugs in Appalachia. And so I am excited to report out what the goals, the handful of goals that we came up with. I know that we were charged with coming up with 3 recommendations, but we have, I believe, a total of 6 recommendations. So I'll apologize in advance for not following the rules. But I will say that part of our recommendations came from things that were mentioned throughout the summit today. And then other things hadn't been discussed yet. So I think it's important for us to at least document all of the recommendations that were discussed by the group. The first recommendation that we came up with was one that was mentioned earlier in the summit, which is the importance of continuing to leverage telehealth. We heard from a speaker earlier today that we've already seen telehealth begin to dwindle a little bit, despite not being out of the pandemic yet. But this has been a really important tool to increasing hepatitis C treatment, particularly in rural areas. And so our first recommendation would be to continue to leverage telehealth post-pandemic. The second recommendation, we heard very beautifully from Nick Voiles on this topic, and it's about the need for rapid diagnostics for hepatitis C treatment. And so I was sharing with the group that we're making some headway in this area, but there's more work to be done. And so there aren't yet approved diagnostics here in the United States that will allow us to diagnose someone within a matter of minutes. The tests already exist in other countries, but they're not available here in the United States. And so we know that the FDA is working diligently to remove any regulatory barriers for being able to bring those tests to market. The CDC and the Association of Public Health Laboratories also co-hosted a meeting at the end of October on this very topic. But I think the important thing here is that it's going to take involvement from the community, particularly from people who work in harm reduction settings and community-based organizations. It's going to take you communicating the need to our federal partners and to these manufacturers of the tests, why it's important to bring these tests to market. And so if diagnostics happens to be an interest of yours or is a need that could be met for your community, feel free to reach out to myself. I can get you connected to some advocates that are working on this issue right now. The third recommendation that we discussed was the removal of payer barriers, including prior authorizations, specialist requirements, and sobriety requirements. And those two requirements we see have a large footprint in Appalachia in particular. And so we wanted to be bold and recommend the removal of prior authorizations altogether, which we are seeing some states do across the country. But at a minimum, we need the specialist and the sobriety requirements removed. The next recommendation is increasing access to hepatitis C treatment in harm reduction settings and other settings that serve people who use drugs. And that can cover a whole range of areas. And certainly it's a multifaceted task in terms of the barriers, like payer barriers, in order to provide access to treatment. But we think that that's an important piece of meeting people where they are. And then the last two recommendations I'll just briefly mention would be an anti-stigma campaign for providers. We've heard a lot about stigma today. And then lastly, sometimes it can be challenging to maintain updated contact information when we're thinking about even diagnosing and linking someone to care. And so partnering with our community-based organizations that are, again, have routine contact with patients to get them linked to care is a really important piece of this. And so with that, I will yield it back to you.
Thank you so much, Adrian. You have set an extremely high bar for your colleagues to meet. So thank you and your group for all your hard work. Next, we're going to hear from Jay Mason.
All right. Thank you so much, Ronald. Hey, everybody. My group was the medication-assisted treatment group with people who use drugs. Obviously, a big topic, a lot discussed. Some of the recommendations were around extending the coverage and really promoting the coverage for pregnant women after their pregnancy is completed. We see them kind of drop off of care. It seems their care is pretty good during their pregnancy, but we don't do the follow-up. So really kind of promoting and really enhancing those services after that is one recommendation. And then as far as for medication-assisted treatment, we see a lot of increase in providers prescribing MAT, but also we're also seeing a lack of access to the medications in the pharmacies. So how to kind of level that out a little bit, where there are a lot of requirements in the pharmacies as far as caps and things like that, but just how do we alleviate that, especially in Appalachia with access is an issue. In West Virginia, where I'm from, not a lot of pharmacies to go to, so getting them access to their medications is another barrier. So we really want to try to push for that to get kind of bumped up to where the access is good. And then one thing that was brought up by one of our members, Dr. Cooper, was the upcoming new injectable for medication-assisted treatment that'll be last a week. So this could really be a game changer. So we really want to promote that. One of our recommendations is really, learning more about that, getting in on the kind of the ground floor, because it could be a game changer as far as, it's a once a week instead of having them come so many days during the week, where transportation and things like that are obvious barriers in Appalachia. So we just think that would be a great way to kind of enhance the MAT treatments around Appalachia. And then it gets back to kind of what Adrian and their group was saying around all the policies and the red tape around getting access, right? Just not only from hepatitis C, treatment, but also with MAT, all the prior auths, things like that, trying to make it a little bit more, attainable for some. So we really want to try to recommend to get that red tape out of the way. And then something also that Adrian's group talked about, but really pushing that when people come in for MAT treatment, they're getting treated for their hepatitis C. We really want to recommend that it's done, when you got them in the building, got to capitalize on it and make sure that we're doing that. So that's the last recommendation from our crew that we talked about. So thank you.
Thank you so much, Jay. Again, another excellent job. Thanks to you and your group. Michelle, you're up next. What do you have to tell us about your breakout group?
Our breakout group was fantastic. We had a lot of navigators on there, so you get a lot of passion and kindness, and also a lot of experience. So we did end up talking quite a bit about some of the stuff Adrian mentioned. I would say that our top tier was really this idea of a one-stop shop at syringe service programs. Don't make people, remove as many barriers as possible, and really engage engage with people who use and inject drugs at the place that they're comfortable, and don't send them all around town. That was really big. So with that came two other issues. This one, I just love the theme of this all throughout. It's really about peer navigation and peer advisory boards, and really making sure that we're taking our cues from the people that that know the most, that have the lived experience and can really direct us in the right way. We did talk a bit about the FDA approval for getting a diagnosis. And so instead of, again, kind of this one-stop shop, sending people away and saying, hey, could you come back whenever, really getting that diagnosis. And I think from the community, that's helpful because then they actually know what to do next versus like, oh, well, what should I do next? So that was a big thing. We talked about the policies that that folks thought really needed to be addressed in terms of how, from a harm reduction perspective, we could do quite a lot. And that was really about addressing the issues associated with the prior approval, and which I always say is a provider benefit, but also the prescriber restrictions, and removing that barrier. And so Kentucky did remove that barrier, but it sounds like it's still a big deal, and we're starting to see some changes in Kentucky about it. So top 3 policy priorities for improving harm reduction services are would get rid of the prioritization, get rid of the provider prescriber restrictions, and get that FDA platform approved so that we have a diagnosis when somebody walks in the door and walks out the door. Really engage in peer advisory boards and peer navigation. And I love that piece. And then my last shameless plug is to really consider moving from injection language to consumption language so that people can reduce the risk of bloodborne pathogen acquisition by having knowledge of other routes of administration. But a really, really robust conversation, very talented group.
Thank you. Thank you so much. Again, I'm really impressed by what I'm hearing. Thank you as a moderator and your participants. And last, we're going to hear from Nick. Nick, what do you have to share with us?
So we talked about overdose and an overdose strategy in relation to an hepatitis C plan. Of course, the idea that if you don't keep someone alive, they can never be cured was first and foremost. Some of the people talked about that they're handing out naloxone where they're at, and we talked about the necessity for that to be a part of the actual viral hepatitis plan. There's an idea that like naloxone and viral hepatitis suppression or elimination are two different things. We start to uncover this onion and realize that like we can hardly even talk about giving people treatment for HIV or HCV if we don't first make sure they're okay. Make just simple basic health, make sure that and that starts with being alive. It also is easier to bridge a conversation with someone who's reversed his friend's death by naloxone obtained from an SSP or another service. It gives you a level of trust, We also talked about that being, the stuff that we internalize and bring back out, the external stigma plays into the internal stigma, plays into like bad outcomes when we're trying to get cured or trying to find treatment from a place. We then talked about like what should a person, how does a person involve a, not just naloxone, but like an overdose reversal strategy? Where does it start? How do you implement it and put it into something that relates into, relates to HCV? And I think that the idea is that drug users want to be healthy. They want to be cured of their diseases. The problem we see is that they beat this drum every time is that cascade to care, that time it takes to get cured, and if they're dead, they can't even enter into that. So, I like the one-stop shop idea. As an SSP, we should be able to have low threshold, methadone and bupe, induction, not actual services, but induction at least. Then we should have hepatitis C treatment and cure. It's a really hard nut to crack if you're giving somebody the idea to get safe and cured through hepatitis C, but you're not offering them a way to stay alive to come get the cure, then what are you doing? I mean, with our new drug supply, we don't have a choice. You know, it's not like we're looking at something where we can say, you know, oh, we'll be safe. You know, there's no safety anymore. It's all polluted. It's all got people. You know, it's all rolling of the dice. So we talk about overdose plans. We talk about all these things. When you start laying in plans with people and you start getting them to think about themselves and wanting to stay alive, it's a really easy sell to say, hey, can I cure you of your Hep C? Like, it's unreal. It's like, it's just these simple things, you know, a little bit of dignity, whole lot of love. Treat, you know, hey, here's naloxone, and give it to your friends, and we'll train you to train your friends. They see trust. You know, it's just like, you know, oh, well, he's wanting us to stay alive. That opens the door for 1,000 other wonderful interventions. So, and, you know, a couple of us are just starting SSPs in places over the call that we're talking about, you know, talking about how to reach those people and learning how to do that stuff. So that was it.
Well, that also is very, very helpful, Nick. I really appreciate it. I know you didn't have a huge group, but the recommendations that you folks came up with are very helpful. So I want to remind the audience, I have one question so far, which is really easy to answer, which is Jonathan wanted to know if continuing education credits were available for this. And unfortunately, the answer is no, Jonathan. But so that was an easy question to answer. But I want to invite the summit participants to make any comments or ask any questions. And I would like to also say in particular, if any of you out there, and this applies to the moderators as well, but certainly all the people in the who are participating, if any of you out there are aware of successful efforts that have actually maybe incorporated one or more of these recommendations. It doesn't have to be statewide. Maybe it's just in a facility. But I mean, also what we want to try to do is find out, are there any activities taking place on the ground that could be scaled up? So I don't know if folks have any comments about that. But in addition to questions and comments, you know, again, put them in the Q&A and we'll share them with the entire group. If not, you know, I'm rarely at a loss for words, so I'll come up with some questions of my own. Let me ask Adrian, I mean, this issue of, in particular, the sobriety and specialty requirement barriers, we know what, let me see if I can be succinct. What are the lessons learned from the successes in reducing the fibrosis barriers that might be applied to kind of getting rid of this kind of, I mean, it's not the only barrier, but it's a pretty significant barrier, especially in states where there might be a handful of gastroenterologists the entire state. So do you have any thoughts about that, Adrian?
Yeah, I'd be happy to share. So, you know, fibrosis is somewhat unique in the sense that we were able to use litigation in a number of cases in order to get those restrictions removed. And we don't feel as confident in our legal strategy around removing some of the other requirements. But what I will say is that an effective strategy that can be applied to any of these requirements is the power of grassroots advocacy. And so we have long worked with both patients and providers to help identify who are the people in your state that are making these decisions. And oftentimes it's a committee within the Medicaid program of physicians and pharmacists who you may even know. If you looked at the list, you may even recognize some of those names of people in your state. And a lot of times it's about building relationships with them or sending them a letter to say, you know, these are the reasons why these barriers are how these barriers are impacting our community. Or maybe it's showing up at one of their meetings and providing public testimony. And so we have, having those people hear from their peers as well as from patients has been an incredibly impactful advocacy tool in helping remove a number of these restrictions. If you don't ask, the answer is always no. And so, you know, it's certainly more challenging in some states than others, but I was just sharing in our breakout room that 8 states have removed prior authorizations entirely for hepatitis C treatment. And unfortunately, none of those states are in Appalachia, but Virginia, effective January 1st, will be removing prior authorizations for hep C treatment. And so perhaps that will encourage some of the neighboring states to consider that strategy as well. So to answer your question, I think, we can't underestimate the power of using our patients and provider advocates and figuring out who is making the decisions in your state. But certainly in the case of fibrosis, we had to use litigation at times to help push us along.
Great comments. And I think that the part of them reflect back on, I think, what Nick and others talked about of individual stories from people about, this is how this restriction impacted my father or my sister or my mother. Let me pause here. We do have a comment that came in from Barbara, and I'm going to read it. Jay, if you or anyone else from West Virginia want to comment, have at it. But Barbara wrote, the Kentucky Hepatitis Academic Mentorship Program was successful in working with the prescriber restrictions in Kentucky. West Virginia has the same model, and a national model is available for states to use as well. Harm reduction is a core component of the program. It's not all about viral hepatitis. So, I think we may or may not have a response to that, but, I just wanted to share that. Jay, do you want to comment on that at all, since a West Virginia program's called out?
Yeah, harm reduction is the big bugaboo in West Virginia. That's we were making strides, and now we've been, roadblocked. And so that is an issue. There's no doubt about it, because there is more to it than just, the HCV treatment and things like that. So, I agree with you. The program you're talking about, very familiar with that. There's that opportunity in West Virginia. There's also the ECHO program that we have in West Virginia, and also spans actually into Kentucky with some spoke sites there. But I agree. I don't know, what's the answer, for the harm reduction thing. I'm not sure. I don't know.
Okay. There is a comment from Shannon, AKA Danny. And I'm not sure if VA refers to the state of Virginia or the Department of Veterans Affairs, but the question is, with regards to VA prior auth, what can we do about providers that are requiring sobriety to treat? I think Adrian answered that in part. I will tell you that before I retired from federal service, I actually worked at the Department of Veterans Affairs headquarters. And I don't know the current state, but I know as of a few years back, we were able to put language in the policy that said that sobriety was not medically indicated prior to treatment of, if you're talking about the Department of Veterans Affairs. Oh, she means Virginia, or he means Virginia. But Adrian kind of commented on that. Let me give others a chance. Does anyone else want to add to what Adrian said about how to tackle the sobriety requirements that some states still have?
And it's not necessarily just sobriety or fibrosis or prioritization or provider prescribing restrictions. And what we've seen in Kentucky is that all those have been removed, and over a series of time beginning in 2018. And what we really saw doing a large Medicaid data study and analysis was that even with restrictions removed, if providers don't know that they're removed, it doesn't change. So you have change in policy, but you don't have change in action. Yeah. And so I think that even after we have these accomplishments, that we can't take our foot off the gas on this one, and that to me becomes a really important piece. So like, we've made all these strides, and yet we still can't get people treated because now we have a provider barrier it's almost like an administrative hangover. Yeah. Is how I think about it.
Yeah. Well, I think you were channeling one of Brittany just commented that removing the Medicaid restrictions is just the first step. Then you have the challenge of educating the providers to get them on board. And I think those of us who worked in the HIV field know the example of routine HIV testing. I mean, it took over a decade after the recommendations were changed to get substantial improvement, and then still there were some places not doing it. So point well taken. Seems like, Adrian, we have another question specifically for you. It seems like people are especially interested in the Medicaid restrictions. And Andrew asks this question: can Adrian speak to some of the rationale that Medicaid programs have given for not removing sobriety and prescriber restrictions? Let me hang on a second. Yeah, so in other words, he's trying to get a sense of what's worked in states that have removed them, and what are the kind of arguments that you hear at a policy level from the Medicaid folk who say, well, we're not going to remove them.
Yeah, sure thing. So on the topic of sobriety restrictions, the rationale that we most often hear is the concern around reinfection. And while we don't have great data around reinfection, we can relatively confidently say that the reinfection risk is pretty low. And certainly from a public health standpoint, the benefits outweigh the risk of treating someone, regardless of whether they're continuing to actively use substances or not. And so we can refute the reinfection concern all day long, but that's typically what's cited in terms of sobriety restrictions. For the prescriber restriction, the most common rationale we get for that is a lack of education. And so someone brought up the comment around provider training programs earlier, and certainly those can be helpful in helping providers feel more confident in treating hepatitis C. And they shouldn't be a barrier to treating hepatitis C. And so we heard from one of our earlier presenters that in West Virginia right now, the turnaround time on getting a consult reviewed by a specialist is 4 to 6 weeks with COVID. And that's a really long time. And I think she said that even pre-COVID, it was 2 weeks. Even 2 weeks, in my opinion, is a really long time. And so while I think that there is a role for provider training programs, I also don't think that they should be a barrier. We should be, once a provider feels comfortable in treating, they should be able to treat. This isn't rocket science.
Yeah.
And so we've got to do a better job of removing some of these artificial barriers.
And I think if I can just add, I'm sure that Jay would chime in at this point and say that the ECHO program, which it started in New Mexico and has been adopted by other states, is a way, in fact, that providers who kind of want that backup. It's not a requirement, but they might have a complicated case or they need backup. They can treat, and through that telehealth mechanism of the ECHO, that's one way to make sure they have that backup. So there are strategies to people who say, well, yes, but what if you have a complicated case? Jay, do you want to add?
Yeah.
Jay, you want to add to that?
Yeah, just so, I agree with Adrian. We don't want barriers. That's, that's the, counterproductive. And obviously, help mentoring and training for those providers if they need it to get to a point where they feel comfortable and they can just go and do what they need to do. That's what our goal should be. And that's what our goal is at ECHO. I will say what we've tried to do is we've worked with Medicaid, presented a lot of data on the fibrosis score and the sobriety. And now if you present a case at the ECHO program, that counts as your specialty consultation. That was the compromise in West Virginia, that, there's not enough specialists in West Virginia to do these consultations. It was so much longer than 2 weeks, before all the ECHO stuff and things like that. So I agree. We don't want to, everybody, that can prescribe should. That's the rule. That's what we want to eventually get to in West Virginia. It's gotten better, but it's not to where it should be.
Okay. I think Michelle, this might be to you. I'm not sure who made the statement, but Joey is asking for a clarification. And I'll read her question, Joey's question. Did she say earlier that pre-authorization for treatment will no longer be needed in Virginia by January 2022? Who was that, you, Adrian, or was that Michelle?
That was me. And yes, that is true. January 1st, prior authorizations will not be needed for people who are being treated for the first time in Virginia through Virginia Medicaid.
Okay, thank you for clarifying that. Let's go on the subject of pharmacists, which again, I think some of you know that my initial entree into public health many decades ago was the HIV epidemic. And there was a lot of work with pharmacists, some successful, some not so successful. And I think, that's part of why I'm interested in this. But I guess the question I'm asking is, any of you can respond to this, do you think there's any leverage in working with national pharmacy associations to develop either quality standards or principles of practice that could be used to try to convince local pharmacists who don't want to, fill prescriptions for Suboxone or whatever? Is that a strategy that could be employed? Anyone can comment on that. Any of the moderators.
This is Adrienne. I'm happy to take that first as the pharmacist on the panel, although I don't want to take up too much space. Yes, I think there's absolutely a role for that strategy. I will say that the other important piece here is that we've got to hold particularly larger chain pharmacies where I think a lot of the stigma is maybe being perpetuated and the denials are happening. We have to hold them accountable and make sure that they're training their pharmacists and other pharmacy staff about what the right approach to these situations are. There is one of the earlier presenters shared an NPR article around what kind of pressures pharmacies are feeling from the DEA around this topic. And so there is some legitimacy. I heard earlier that, from the primary care provider side, there's some fear around prescribing these medications. But then in the pharmacy side, it's like people just deny it. Well, there's also some fear around the DEA's involvement in dispensing these medications that I think everyone would benefit from having a better understanding of. And so both working with these major chain pharmacies, because the reality is that a lot of patients seek care at these locations. And then secondly, working with the larger pharmacy associations around what training they can provide to their members around stigma and harm reduction is incredibly important as well.
Yeah. To make an obvious point, because of the delayed but much needed publicity around overprescribing of opioids by pharmacies, I think it's had the unintended consequence that people who really need medication, whether it's opioid for legitimate use or it's replacement therapy, are having trouble getting it. I want to make a general comment. I've had 3 or 4 comments come in listing websites either related to training for hepatitis C or resources available. I am not going to mention those during the Q&A, but what I would say, I don't know, to our technical people, if there's a way to capture those so that Susanna and Daniel have a record of that, because one of the goals of this meeting was to put together a resource list to share. So rather than kind of, repeat all of them individually, if there's a way to capture that, I just wanted to make that comment to our technical people. I have a comment from Rebecca. In North Carolina, if a pharmacist refuses to fill a prescription for whatever reason, by law, they are supposed to help facilitate getting it filled, meaning by another pharmacist or at another pharmacy. So when we've run into this, we've reported it to the Board of Pharmacy, which I think personally is a good strategy.
Yes, I would agree with that.
I think that's a real good strategy. So let's see what else. The stigma issue, which is so important, but so pervasive, whether we're talking about, at a provider level, at a legislative level, at a community level, even internalized stigma. Are any of you aware of campaigns or efforts that you think have been successful, especially successful in trying to get people to see this as a brain disease? I mean, we had that comment earlier from the woman at Olive Branch. It's a brain disease. it's a medical disease. Why are we victimizing people? But any of you know of particular efforts in Appalachia that have been successful, even if they're at a very local level?
I mean,
go ahead, Nick.
I'm sorry, I just misunderstood as soon as you said it's a brain disease. I kind of went clear to the left there, I don't think that it's just as simple as that. I think that the idea that Maya Salvitz came out with a book recently called Undoing Drugs. And one of the things that I like that she says in it is she says, it is part addiction model. It is part, this model, and it is part learned behavior. So when we're looking at what exactly encompasses, substance use into chaotic, moving into chaotic use, there's all these incremental ideas that can fit into one, but that don't work on their own. I think more to the point that I think we're trying to set things up there, especially in North Carolina. We have some efforts doing open doors. For instance, like here, we opened up with masks. We allowed people to socially distance, but inside our place, trying to grab in closer. A lot of people during COVID pushed away, and it creates this no touch, no feel. I don't know how to explain the right way to say it, but it creates a separation that just further pushes into stigma. It's like we already have enough stigma about what's going on. Then we think we're dirty. Then we think you don't want to touch us. Then we think we don't want to touch us. Then we get some meth. Then shit goes crazy. And then we're in some place we are looking at Shadow Man outside trying to, wonder what we're going to do if we have to move 4 feet, I think a lot of it is just that the problem is so darn complex that until we take away the punitive aspect, we're stuck in this reoccurring nightmare. HIV, we have HCV, we have a cure. Damn it, man, we have a cure. It's that fucking simple. Sorry for cussing, but it's that freaking simple. If they gave one iota of the push to HCV that they gave to anything else, we'd be done with this. We'd already be talking about, hey, we've just cured blah, blah, blah amount of people because we could just give them the cure, no problem. But I think until we look at this broad idea that we're sticking this healthcare system that doesn't really work, that doesn't really cater to people, and we're saying, fix it, fit into this model.
Yeah.
Doesn't matter if you have problems, fit into this model. We're never doing anything because
time to change the model.
Yeah,
it's time to change the model. Well, there is something afoot in the broader medical world called complex care, which people are saying well, maybe the problem is that the models aren't working for people who have a lot of physical and social and psychological problems. Well, listen, on that note, I want to thank the breakout groups for all the hard work you did, because you folks generated a lot of excellent recommendations. And I want to especially thank our 4 moderator rapporteurs for being able to feed all that back in the time frame allotted, which wasn't terribly generous. So you guys deserve, all of you, including the participants, deserve a lot of credit. And at this point, I want to turn it back over to Daniel Raymond, who's going to go Daniel.
Go Daniel.
Who's going to Daniel and then Suzanne are going to close out the meeting. So Daniel.
Thanks so much, Ron. And again, thanks to all of our breakout moderators and rapporteurs, and to everybody who attended today, who contributed your thoughts, your experience, your ideas, your questions. This was exactly what Suzanne and Ron and I were hoping for. And I really enjoyed and learned a lot from the discussion in ways that I think are going to enrich. Where I work with Adrian, as well as our colleague, Robin Lord-Smith, does have a patient and provider advocates network called Voices for HAP. And if you visit us at nvhr.org, I heard a lot of energy around looking at changing or affecting Medicaid treatment restrictions. I'd encourage you to plug into us, find our email addresses there. And if there's ways that we can support you, if there's ways that you're looking to get involved, please do, because I think one clear message that I heard throughout all of the conversations today is that we are at a fork in the road, and that that this is an interesting and dangerous time where we have meaningful opportunities to move the ball forward on a number of different fronts. But if we aren't thoughtful about our actions, and if we're not coordinated about them, then we and the people and communities that we care about stand to lose a lot. So I think that events like this give me hope that there is a wellspring of people who are thoughtful, committed, and dedicated to figuring out how we can work together to remove barriers, improve access, and ultimately protect people's health, lives, and overall safety. And so I'm eager to pick up this conversation in the future and talk about how we all work together to achieve our shared goals. And with that, I will turn it over to Susanna. Thank you,
Thanks,
everyone.
Daniel. Thank you so much. So well said. What an excellent program today. I'm so excited about the outcomes of our breakouts and all the great information that was shared today. We thank you for participating in this first Eliminating Viral Hepatitis C Among People Who Use Drugs in Appalachia Summit. Maybe we'll make an acronym for that. Daniel, it's awfully long to say. I do want to thank our planning committee members once again who helped to bring this to life. I want to thank all of our speakers, plenary panel, and we, what an amazing group of thought leaders we cobbled together. And we thank our moderators for leading those breakout sessions and bringing that information back from the groups. And we will collect that information and share that widely. This summit was recorded, so we will also be able to, in a few days, post that and share this for those who want to revisit and those who weren't able to attend today. And I want to thank Dr. Valdesari for being a part of the planning committee, but also for being today's summit moderator. What a great job keeping us on track, Ron. But this is one of your strong suits. So thanks so much for making things run so smoothly. And we couldn't have asked for more. And I absolutely want to thank my national director, Amy Luxton, and Encore, who are behind the scenes working their magic to keep all of this going. It was not easy, trust me. And our sponsors, the National Harm Reduction Coalition and the Viral Hepatitis Roundtable, AbbVie, Gilead, and UPMC for financially supporting us. And our hope is to make this the first in a series, as we talked about earlier, and your feedback is so critical to that. We hope you enjoyed this today, but we want to hear what you learned, but what you want to hear more about, what you want to learn more about, what we can do better and different for our next summits. And we're always looking for folks to help us on the planning committee and to share great information and new ideas for our future. So I just want to wish you all a great rest of the day. Don't forget to participate in the evaluation, to share those thoughts and feedback. And we're definitely stronger together. We look forward to forging stronger partnerships and moving our mission, our collective missions forward. So thank you so much and have a great rest of the day.